Yes, we will
Wonderful.
do definitely.
Please, thank you. Yeah, so once again, welcome all on the board of Medical MCQ for All. Those who are joining first time to Medical MCQ for All, today's class would one of the best class for sure. As usual, we have the best class, but we have tremendous speaker with us, with me now. So let me introduce her. This is Dr. Akansha Gosavi. She is a internal medicine and she is having a vast experience in teaching, coaching and things, right? So this is what the thing is. So she has a 10 plus year of experience in teaching, coaching since 2015 and she is like on the various national and international platform for coaching for NEET PG and MBBS, FMGs, foreign medical graduate, next aspirant and lot more. She has like several achievements, right? Long list, but I'll make it short. She is academic strategic and content head for emediskill.com, lecturer of internal medicine faculty, right? On prosum.com. This is also online platform. And the great thing is that she's official international MCI faculty. MCI means Medical Council of India slash National Medical Council. So she is internal medicine and she has vast experience delivering the lectures for foreign medical graduate or students studying in abroad, especially the Caspian Medical University, Russia, Kazakhstan, and a lot of academic and papers and authorship on her name. And she is also author for PG Pulse, right? And all in one. I mean, she is a tremendous speaker. So I would like to learn from her as well today. So we are, I mean, this mock test divided in two parts, like 12 to 1, 1:15 would be first class of Dr. Akanksha, probably 2 to 3 minutes break, and then back to back my class, probably at 1 o'clock to 1:15. Late by 1:15 would be my class. So we'll pack up by next 2 hours. So just stay tuned and concentrate, and it is open platform for discussion. So whatever the queries or questions or concerns, right, you can ask to the doctors, Dr. Akanksha directly, right after finishing the question. Also, you can connect to her. So that's it. I will introduce other my faculty. This is Dr. Arti, who is a consultant pediatrician, and again a very brilliant speaker. Dr. Maddy, as usual, very popular. Myself, Dr. Munjal, and our team as well, Dr. Meghna, Dr. Sonal, Dr. Akanksha, as you know. And this is the team also. We have Dr. Kainath will join very soon for homeopathy, Dr. Pooja for dental, and everyone probably knows the Pallavi. She is like our backbone and these things. So I'll just quick pass on the few slides and get, I mean, hand over to Dr. Akanksha. This is our official YouTube channel, Medical MCQ for All. So there are hundreds of videos. So I strongly recommend that you see at least one video a day, which clarifies a lot of concepts as well, right? And these are our mobile application on Android and iPhone. So those who are net savvy or mobile you friendly, they love mobile, they can use whole the website from our Android and Apple. You can just download it, right? You try to do the mock test every time. I'm telling each and everybody, mock test is a real secret of success. More the mock test you will do, more the idea you're gonna get how much score you are doing. You can do the self assessment, and we have subject wise and we have different, various mock tests on the website. So try to do it before you go for the exam. And we are launching two main programs, dental and homeopathy will coming soon, right? So probably in a week or two, we are just waiting for final touch. And these are all our things, right? The menu discounted package, one of the best is 350 wala, where you're gonna get everything: book, website, coaching, subscription, WhatsApp, and lot more. So without wasting the time, I will be glad and happy to invite and introduce Dr. Akanksha. So you can please take over the platform and you can start with your lecture. So I would like to invite Dr. Akanksha, please.
Hello, sir. Good afternoon. Thank you so much for the wonderful words and a brief introduction about me. Good afternoon to all the students as well. I hope I'm audible to everyone.
Yes, you are audible well, and I'll make you the host as
Okay.
well, so you can have the command of the things.
Okay, thank you.
Oh,
Thank you, sir.
yes, yeah, we can start.
Yes, I'll be just sharing my screen. Give me a minute. Okay, so without wasting the further time for today, all the doctors, here is our first question for today's mock test. A 48-year-old man presents with severe epigastric pain, radiating to the back and vomiting. He has history of alcohol intake. Serum lipase is 620 units per liter. What is the most specific laboratory test for diagnosing acute pancreatitis? And your options are below: serum amylase, serum lipase, ALT, serum CRP, and serum bilirubin. So just take 5 seconds to analyze this and post your answers. We'll be discussing this question. Please be careful about all the buzzwords that you see in the question. The buzzwords are going to be severe epigastric pain, the age of the patient radiating to the back, vomiting, and the levels of the lipase. So we need the most specific laboratory test. Yes, I started getting the answers. Okay. So majority of the people are saying it is serum amylase. Dr. Ishara is saying it is serum lipase. Yes. Okay. So let us discuss this question. Now, as we know that this is the case of acute pancreatitis, and here we have to just be concentrating on one word, that is the most specific thing. So now, whenever you see a patient of acute pancreatitis, you have to always remember there is going to be epigastric pain radiating to the back, accompanied with vomiting, and it can have a history of alcohol. So it has to be acute pancreatitis. This is the classical things that a patient will present in acute pancreatitis. Now, what is acute pancreatitis? It is a acute inflammatory condition which is caused by the premature activation of the digestive enzymes. As we all know that the pancreas secrete the digestive enzymes, which leads to autodigestion or autophagosis of the pancreas with along with the inflammation and possible necrosis. So whenever we talk about this, we have to first clarify that what is acute pancreatitis. Now, coming to the most specific laboratory test. Now, here the answer correct has to be your serum lipase. That is the correct answer. Why serum lipase is the correct answer? Let us see. Now, what happens is serum amylase, yes, it is also raised in pancreatitis, no doubt. But serum amylase is not specific for the pancreas that it is released from. Serum amylase can be released from your salivary glands, at times your ovaries, your intestine, and sometimes in small proportion from your lungs as well. Okay. But serum lipase is very specific to your pancreas. And also the half life or the total duration of serum lipase to get raised in the body is going to be from 7 to 14 days, which generally is a very good prognostic factor or a very good diagnostic factor whenever you think of acute pancreatitis. So the serum lipase has to be your correct answer. Serum amylase, why it is not the right answer? Because it is not very specific to pancreas. So keep this in mind always. And as I discussed, that whenever you're diagnosing about acute pancreatitis, four things should always come to your mind. First is severe epigastric pain radiating to the back, accompanied with vomiting, and which has a history of alcohol, at times cannot have a history of alcohol. Also, the serum lipase has to be very highly raised, or it has to be threefold high as per the normal values. Now, let us see the explanation for it. Okay, so the correct answer is serum lipase, which is, as we know, that it is more specific to the pancreas. It remains elevated for how many time? It remains elevated to 7 to 14 days after it rises. And it is less affected by the hypertriglyceridemia. So whenever a patient of acute pancreatitis is presenting, there has to be higher triglyceride levels as well. But lipase is something that is not affected or doesn't fluctuate with the triglyceride levels. And it is the most preferred diagnostic enzyme. Now, the next thing that we would like to discuss here is whenever we think about acute pancreatitis, we also have to know the diagnostic criteria. These days, they have asked a lot of questions on the diagnostic criteria for acute pancreatitis. It has to have any two of the three main symptoms. Okay. So, what is the criteria? Typical abdominal pain. That will be your first criteria. Okay. Then will be your serum amylase and your lipase. So, now when we talk about serum amylase or lipase, first is the abdominal pain. The abdominal pain has to be how? It has to be your epigastric pain radiating to the back. Epigastric, and it has to be back radiating. It is never going to be radiating toward the inguinal region or radiating towards the center, or maybe it can never show a McBurney's type of pain. It has to be your typical abdominal pain which radiates to the back. Then you have serum amylase lipase three times higher of the normal level. Also, your USG or your CT, that has to show the evidence of pancreatitis. USG or your CT scan, what you will do for the abdomen, it has to show the evidence of pancreatitis. So these are the major diagnostic criteria for confirming whether it is pancreatitis or not. Now, when we think about the amylase and lipase, where all the students they generally tend to get confused. Now, we'll see about amylase lipase. High specificity for pancreas is always higher in lipase. Therefore, our answer correct was lipase and not amylase. Why amylase not? Because amylase is secreted from other places also, as well as your pancreas. That is your salivary glands, your intestine, your ovary, and your lungs. Now, the duration to rise for this lipase is going to be 4 to 8 hours, and it is going to stay in the body for 7 to 14 days. But here, the duration for the amylase to rise is going to be 6 to 12 hours, and it is going to be in the body for 3 to 5 days, which is lesser time or lesser duration as compared to lipase. Now, this factor is important because when the patient sometimes is presenting to you late, he's coming on the day 5 or the day 7 of his illness. That time, how will you diagnose it? That time, the lipase will have a role because it is going to be raised in the later period. And does it affect by triglycerides? No. But sometimes your amylase can be high because there is a metabolic pathway interlinked for amylase and triglycerides. Therefore, they are dependent on each other. Okay. So here also we have mentioned what is the normal values of the lipase and the amylase. Now, when you talk about the normal values for the lipase and the amylase, lipase is going to be 10 to 140 international units or units per liter, and the amylase has to be 30 to 110. So this is the normal values. Normal values is also indicated that you should be remembering while answering your exam questions. Sometimes they can mention you, sometimes they cannot mention this. Now, coming here for another section of diagnosing or maybe what are the risk factors that can lead you to acute pancreatitis. Now, understand, once we are doing a question for acute pancreatitis, I want you all to understand the whole of acute pancreatitis step by step so that any form of question comes, you will be easier to understand this. Now, what are the other risk factors or what are the other causes that can give you acute pancreatitis? Here, it can be due to related to the gallstones, may be related to the alcohol or your raised triglyceride level, which look at the levels, the normal levels are 150. But if it is more than 1000, then also it can cause you acute pancreatitis. There are few drugs like azathioprine, valproate, sodium valproate, that is the most common anti-epileptic drugs used in the older times. Sometimes the thiazide type of diuretics. Also, post ERCP procedure, that is post removal of the gallstone. That time also it can cause you pancreatitis. Trauma, it can be the blunt abdominal injury after the road traffic accidents or any other cause. So these are basically all the causes or all the risk factors which can lead you to acute pancreatitis. Now, whenever we see the patient for acute pancreatitis, we would like to know that how would we manage this patient. In management, always remember the patient of acute pancreatitis, has mortality due to two things. First is your hypovolemia, and then is your multiple organ failure. So the patient is not going to die due to any other cause in pancreatitis, but these two are the main causes that there is going to be any type of mortality associated with pancreatitis. Now, whenever we think of that, so the first step in our management has to be aggressive IV fluids. Any type of IV fluids which is going to balance out, that is your NS or your RL. RL at times, if it is accompanied with lactic acidosis, avoid RL, you can give NS. But if there is no lactic acidosis evidence, you can give RL. Okay, so the first step in management of acute pancreatitis has to be the fluids, that is your aggressive fluid management. Second, due to the uncontrollable epigastric pain, we need a higher type of the opioids which will control the pain. Maybe morphine and fentanyl, whatever is available. Then coming for the nutrition, always remember that the pancreatitis, the nutrition has to be kept zero. That is your nil per oral. Nothing should be given by the oral route. Always give the enteral feeding. The reason is
Mm.
pancreas is responsible for digestive enzymes, and already the pancreas is inflamed. The moment you eat food, that the food is going inside, that time the pancreas is triggered to release the digestive enzymes, and we don't want that because it is in the inflammatory stage. So the first rule that we have to keep the patient unless until he stabilizes has to be keeping the patient nil per oral at the longer duration. Then oxygen, yes. Why? Because at times there has to be hypoxia if pancreatitis is accompanied with pleural effusion. So pleural effusion is also one of the complications of your pancreatitis. That time hypoxia can be presenting. So we have to maintain a saturation of 94% on room air. If not, give the oxygen support. And while monitoring, you have to do what? You have to check for the urine output. Whenever we are seeing for the urine output, keep the urine output more than 0.5 ml per kg per hour so that there is no acute kidney injury or there is no type of kidney shutdown in the case of acute pancreatitis. Okay. Now, coming for the severity classification. Whenever we think of acute pancreatitis, firstly, the patient has to be admitted into the ICU. Whenever we are there in the ICU, we have to grade the severity. Now, grading the severity depends upon the side, that is your organ failure or no organ failure. So whenever we say that it is a mild acute pancreatitis, there has to be no evidence of organ failure. But if it is a moderately severe type, it has to be some type of organ failure which is within the less than 2 days, that is less than your 48 hours. And when it is a severe type of acute pancreatitis, there has to be persistent organ failure. Now, whenever we say organ failure, what are the organs that can go into failure with help of acute pancreatitis? That is going to be your lungs, it is going to be your kidneys, and can be your heart. But firstly, foremost, it has to be lungs and then kidneys, and then is going to be your heart. Okay. Coming to the imaging part, USG is the first line imaging to detect whether the pancreatitis is induced due to the gallstones or not. So firstly and foremost, check a USG, or you can do maybe, yeah, your fast scan, which is done in the casualty or the emergency department. So when the bedside USG is done, immediately check for any traumatic case or any splenic rupture or any gallstones or whatever the underlying causes. The USG of the abdomen should be done very first moment. Once you see some evidence of gallstones or once you see some evidence of pancreatitis, later on you can give the patient indication for contrast of the CT abdomen. So CT abdomen with the help of contrast is given only if the diagnosis is unclear or you want to see the further details. But you have to do that after 2 days, preferably once the patient is stabilized. Okay. Now, just we saw that whatever fluids, pain control, nutrition, oxygen, and monitoring, all this will be the steps. But whenever we think of the doses, what will be the dose? The dose of ringer lactate has to be 250 to 500 ml per hour, adjusting to the response. That what we have to see there shouldn't be any hypovolemia. Okay, there has to be no hypovolemia whenever we are talking about this. Yes, Dr. Ishara, I'll just address your questions once I stop explaining the topic. Allow me some time to complete this and I'll address all the questions. You can post your questions in the chat box, not a problem. So, whenever there is going to be IV fluids, we have to stop the patient from having the hypovolemia. Unless until we see a recovery in the hypovolemia, keep giving the IV fluids. Morphine can be given for 2 to 4 milligram IV every 2 to 4 hours just for controlling the pain. The moment we feel that the pain is controlled, we have to stop the morphine or even fentanyl. What is the first side effect that we have to not give any overdose of morphine? It has to be your respiratory failure. So it is going to suppress your respiratory center and therefore we cannot give morphine at a very high dose also. For controlling the vomiting, that is a typical type of vomiting is seen in acute pancreatitis, and that vomiting we call it as a projectile vomiting. So when we say it is a projectile vomiting or which is uncontrollable, for this there is a drug that you call it as ondansetron or granisetron. Granisetron is not used these days. Ondansetron is very commonly used. 4 milligram IV every 8 hours. Okay. Now, as we know that the pancreatitis is going to develop complications. So, exactly what complications does the pancreatitis develop? One will be the pseudocyst of the pancreas, then will be the pancreatic necrosis. Always remember, whenever there is going to be necrosis of the pancreas, supposedly this is your pancreas. So, the necrosis always begins from the tail end. This is the head of the pancreas and this is the tail of the pancreas. The necrosis always begins from the tail end and then goes to the head. But when you talk about pseudocyst, the pseudocyst has to be present at the head and not at the tail. So this is the most common places. It's not that it always has to be this, but I'm telling you that this is the most common place. The most common place for pseudocyst will be the head. The most common place for the necrosis will be the tail. Okay. Then also there can be any abscess. The abscess can be there on the pancreas and it has to show you a symptom of peripancreatic fluid collection. So there will be many USG reports or CT reports that you will find this word peripancreatic fluid collection. So what exactly is this peripancreatic fluid? That is the infectious fluid at times due to the abscess of the pancreas if it is present. And lastly, there has to be the hemorrhage for the pancreas. Okay, because of the rich blood supply from the splenic vessels as well as the gastric vessels, the pancreas can also have a type of hemorrhage. Now, talking about the systemic complications, we know that it can cause you acute respiratory distress syndrome, kidney injury, shock, and sepsis. All this will be the systemic complications. Now, when you're solving the questions, as today this question was there, the most sensitive or the most reliable factor. So you cannot always have amylase alone. It has to be amylase plus your lipase. Now, CT scan before the labs is a wrong choice. You cannot do that. Starting antibiotics routinely, avoid it unless until the cause is very specified or the cause is defined. Then coming to the normal lipase excludes your pancreatitis. Yes, it can say that sometimes you will be, ma'am, the lipase is normal, so therefore pancreatitis cannot be there. No, at times it can be that your lipase is normal, but still the patient is having acute pancreatitis. Now you have sometimes the triglyceridemia, the triglyceride levels, which has to be more than 1000. Yes, someone is trying to say something.
You can mute all, ma'am. If you feel disturbing, you can mute all. You have button bottom line.
Okay,
Those who
one
wants
minute.
to interact, they can interact.
Yes, yes,
Mute
yes.
all. Yeah,
Okay,
wonderful.
thank you, sir. Yeah, so I was there at whenever there are triglycerides, it has to be more than 1000. So if a patient is coming to you, for example, his triglycerides is 1150 and he's only having a mild epigastric pain with diabetes mellitus, then also you can suspect that the patient has pancreatitis. Okay, so this was all about pancreatitis. Also, I would like to show you some high yield image. See, there is edematous and inflamed pancreatic gland. So this whole portion that you see, this is the pancreas on your CT scan. Here you see all the edematous region. Then there has to be inflamed pancreas. Generally, pancreas do not look so big on your CT scan. Also, this is the glands in the pancreas that we talk about, which is going to release your lot of enzymes. And now there are two things which I've not mentioned here. In pancreatitis, you see one sign that you call it as gray turners, which is there going to be the, it is going to be there in the flanks. And one will be your umbilical hemorrhage. Okay, so there will be edematous or there will be venous blood congestion in your umbilical region, or there can be the venous congestion at your flanks, which you also call it as a gray Turner's sign. Yes, now you can ask me the questions or your doubts that you have on acute pancreatitis. Yes, please. What is the specific on enteral feeding? What is that? Nasogastric feeding or jejunal feeding? See, generally we try for nasogastric feeding. Dr. Ishara, this is the answer for your question. We'll generally try nasogastric feeding, but if the patient is non-competent with the nasogastric feeding, we can also try up with the jejunal feeding. And the gold standard is USG, not the CT scan for pancreas. Dr. Ramya, morphine constrict the sphincter of body? No. Morphine at a basic dose is not going to constrict your sphincter of Oddi. Any other questions anyone has about this topic?
Excellent.
Okay. So shall we move ahead with the next question, students?
Yes, madam.
Okay, thank you, sir.
Yes, ma'am.
Yeah. Okay, so question number 2. Now, this is a different topic overall. Let us see what it is. When reading the question, always keep in mind that you present yourself with the buzzwords. What exactly is the examiner trying to ask you? Okay, so read every word carefully. A 55-year-old man presents with sudden, severe pain, swelling, and redness of the first metatarsophalangeal joint. The serum uric acid is 6.2 milligram per dl. What is the most appropriate initial treatment? Allopurinol, febuxostat, colchicine, probenecid, or methotrexate. Okay, so as we read this question, the first words that should come to your mind is going to be a 54-year-old man presents with sudden severe pain and swelling and redness of what? The first metatarsopharyngeal joint. And the serum uric acid is 6.2. So this basically gives us a picture of what? Just take 5 to 10 seconds and see this. Okay, I have started getting a lot of answers in the chat box. And the answer, everyone is saying gout. Very good. Yes, it is a case of gout. And the treatment for acute attack of gout has to be the answer C, that is colchicine. Okay.
Which is
Yes, very good. So now let us see why colchicine we talk it as it is the right management or it is the right thing for gout, because whenever gout comes in mind, first students are going to think either it has to be febuxostat if the uric acid is high, or it has to be allopurinol. But now here it is a case of what? To be specific, if I say we have to call it as acute monoarticular arthritis. So this is a case of acute monoarticular arthritis, which you can also call it as a acute gout. Okay. Monoarticular, why? Because it is only shown that all this pain and swelling, it is only at the first metatarsophryngeo joint. And on the X-ray that you will see this, it has to be podagra. This is the symptom that you will see on the X-ray. Okay, so we'll see it ahead. What exactly is podagra also. Now, when we talk about acute gout, what is acute gout? Acute gout is acute inflammation or acute inflammatory arthritis, which is caused by the deposition of some crystals. So what are those crystals? Those crystals are your monosodium urate crystals, which get deposited in the joints, and then they trigger the inflammatory response. Now this inflammatory response has to be by your neutrophils. Okay, so just I'll mention it once. 1 minute. If you have to think it about as steps. So first what will happen? There has to be inflammation at your joints, which is due to what? Which is due to the ureate crystal deposits. Ureate crystal deposits where? In the joint. Okay. So now whenever there is ureate crystal deposits in the joint, always remember that this causes inflammation, and this inflammation is mediated by neutrophils. Okay. Because of this, there is going to be acute attack of gout. And to be true, the name for this crystal has to be monosodium urate. Monosodium urate. All right. So now the correct answer here in our question is colchicine. Colchicine, why? Because it is a acute inflammatory condition. Colchicine is going to reduce the inflammation in this condition. And here, urate lowering drugs. Urate lowering drugs are all your febuxostat, allopurinol. We cannot be using this because they are not used in acute conditions. They are used for your long-term survival, or they are used for the long-term what you say benefits, but not in the acute condition. Okay, so now let us see the difference between what I say that it is acute gout or a chronic gout. Acute gout, the cause for acute gout or the pathology behind it has to be inflammation, but in chronic gout it has to be hyperuricemia. That is, your uric acid levels are going to be very high. Here the goal is to pain control and then go for the long term management. Okay, first foremost we have to relieve the patient from the symptoms. That is going to be a pain control. Then in chronic gout, what are we going to see? We just have to maintain the uric acid levels. First line drugs for this is going to be your NSAIDs, your colchicine, and your steroids. But here you have to give your allopurinol and febuxostat, which is your urate lowering drugs, or you also call it as ULT. Okay. So now what is the role of ULT here? For avoiding the pain and long-term indication for just keeping in control your uric acid. Now, whenever we see that if the patient also has a comorbidity along with gout, okay, so when the patient is going to have the comorbidity along with gout, give me a minute. So whenever we have this comorbidities along with gout, we have to always check for what options can we give. So if it is the patient with CKD and gout, prefer steroids. If the patient is going to be peptic ulcer with gout, again the steroids. But if the patient is having any of the heart failure or your IHD or any of your cardiovascular conditions, okay, always prefer colchicine because it is not going to affect any of the heart related issues along with this gout treatment. Then you have multiple joint involvement. Gout was this mononuclear. But if you have multiple joints, just like your first metatarsopharyngeal, also your second, third metatarsopharyngeal, all these joints can also be involved, then you can give systemic steroids. That is your per-oral steroids. Something like methylprednisolone, dexamethasone can be given. Now, when we talk about the uric acid in men and women, what are the levels? Men, it is 7 milligram per DL, the highest range. Women, it is 6. So, in our question, the uric acid was 6.2. So, it was an acute attack. Uric acid was normal in this patient. Okay. So, ideally, he'll come under control uric acid, but a acute attack of gout. Just like we have said here, the uric acid can be normal during the acute attack. Sometimes we have to do the definite diagnosis and we can see the synovial fluid crystal. I have an image of what crystals you will see in the synovial fluid, which can be seen under the bifringent polarized light. We'll see that later. Now, the next question will be, when do you start off the urate lowering therapy? Whenever the attacks they are frequent, or whenever we say that the attack is going to be recurrent. When I say that it is a recurrent attack, what is the meaning exactly? Anyone? Can anyone tell me what do you mean by recurrent attack? What is the frequency for you have to see in the gout? Sir, am I audible
Three
now?
attacks, 3 attacks per year.
Yes, yes.
Very much audible, ma'am.
Okay, okay.
Yes, madam.
Yeah. So I was asking students, what do you know by getting a recurrent attacks? What is the frequency of recurrent attacks? 3 attacks per year. Yes, sufficient. 3 to 5 attacks per year is the recurrent attacks, what you call it as. So whenever there is a recurrent attack, you can say that it is going to be a chronic gout. Any patient with CKD. CKD, why? Because already the inflammation in the body is there, uric acid deposits are high. Therefore, CKD patient can have gout as well. Urolithiasis, allopurinol, and what we should be doing, another thing that we should keep here in mind is hyperphosphatemia can also trigger gout. Okay, this is one condition which can again trigger gout. And whenever these are the conditions, you always have to start your urate lowering therapy. Urate lowering therapy has to be your allopurinol 100 milligram per orally daily, and then we have to titrate gradually. The baseline will be always 25 milligram, which can be taken almost to 10 to 15 years. I have a lot of patients who are stable on allopurinol of 25 mg, which they have been taking for a longer period of time. Now, next is like whenever we talk about colchicine, the mechanism of action of colchicine, many of you must not be knowing. Let me tell you that. So, as we saw that the inflammation was due to neutrophil mediated, right? The neutrophil mediated inflammation was there. Now, this colchicine is going to act on the neutrophil mediated inflammation, and to be specific, it is going to act by microtubule formation. So just don't remember that. Colchicine acts on the neutrophil mediated inflammation, and that is the reason that we give colchicine in the acute attack of gout. Now see this. This is the bifringe image that we were talking about. You see this parallel, perpendicular, such types of rhomboid shaped crystals. Yellow color when in parallel to polarized light. So this is how your deposits of crystals will be seen on the synovial fluid. So basically this is your synovial fluid analysis. And this is your podagra. See here, first metatarsopharyngeal joint, uric acid crystal depositions. Okay. Both the images are very high yield. You keep this in mind. Anyone has any questions on gout or acute attack of gout?
I have one question, ma'am.
Yes, sir.
We are seeing a lot of patients in our OPD where they are absolutely asymptomatic, but uric acid level is high. They
Yes, sir.
never had any pain attack or they never had any problem. So how we supposed to manage such type of patients who are absolutely asymptomatic, never had any attack, everything is fine, renal function is fine. So are we going to monitor them or we'll just treat the numbers? What's your
Sir,
experience?
firstly, we have to, asymptomatic, we do not have to give any treatment. Even if the uric acid is like 10, 12, 13, 15, we do not have to give any treatment for that. But once you see that maybe the patient is not having symptoms related to gout, okay? He's not having symptoms related to the bone pain, but you find urolithiasis, you find type of another kidney stones, or you find another CKD that is worsening in that patient. At that moment, you can try giving febuxostat at a low dose just to control the uric acid prophylactically.
Very good. So basically asymptomatic should not be treated if the
Yes,
other
sir.
systems are okay.
Asymptomatic. Yes, yes. Asymptomatic patient with high uric acid level should not be treated. But another rule, that also check for the complications which is induced by higher uric acid.
Fair enough. So everything is if normal investigations, right,
Yes, sir.
pertaining to uric acid, we can wait and watch and monitor, because in
Yes.
practice I usually see for last 20 years is whenever, so like in body checkup uric acid is there, right?
Yes,
In
yes, sir.
routine body checkup uric acid is there,
Yes.
vitamin D is there, B12 is also there. So if
Yes.
uric acid is high, patient is asymptomatic, most of the doctors, this is my field, maybe I'm wrong, so
Yes.
they start this allopurinol or febuxostate and all, they
Not
start in the
recommended.
asymptomatic patient. This
Yes,
is
sir.
what I
Not
mean,
recommended.
general practice in the GP community. So I
Hmm.
think you clear our concept that it should be monitored, should not be treated if everything is fine.
Yes. Yes, yes, sir.
Wonderful.
And as
Thank
we
you very
know
much,
that
ma'am.
we should check for the
Ma'am, up to
urolithiasis or
what
any
level we
other.
can't treat?
Yes,
Sorry.
doctor.
Ma'am, up to what level of the uric acid we cannot treat asymptomatic count?
Till 13, you cannot treat. Normal is still 7. 7 to 13, if it
Till
increases,
13.
that is twofold. Yeah. Twofold increase
Okay.
without any symptoms is safer.
मैम उसके आगे भी विदाउट एनी सिम्टम्स है तो वी लुक फॉर द अदर कॉजेस ऑफ
Complications. Yes.
हाँ ओके
Okay.
Great.
Clear?
Wonderful.
This
Ma'am,
is this
Thank you very
topic
is
much.
clear?
yes, I had doubt.
Yes.
This lifestyle modification will help to the patient.
लाइक मैम दे से डोंट ईट नॉन वेज एंड ऑल सो डज दैट एक्चुअली हेल्प
No, that does not help. But a low protein diet at times, which has a low nitrogenous waste, can help.
ओके
Moderate, sometimes you can say, but a low protein diet is what
Okay.
we generally advise the patient. And
नॉन वेज
another
बंद
thing
कर
which
देना ऐसा कुछ तो जरूरी नहीं होता ना
अल्कोहल भी
नहीं
कम
I
करना है अगर अल्कोहल का हिस्ट्री है तो
मैम एक
I
और
would
चीज
Okay,
बोलते
ma'am.
हैं
Thank
कि
you.
डिहाइड्रेशन की वजह से ये ज्यादा होता है इज दैट आल्सो राइट
add
1 minute, students. One person at a time, please. Someone was asking me a question. Priyanka, Dr. Priyanka. Yes?
I would like to, no, I'm just commenting something. In lifestyle medicine, we have been taught,
Hmm.
even I will share those biochemistry,
So Priyanka,
pathways,
your voice is
where
bit
now we
breaking.
are saying that easy
Dr.
carbohydrate
Priyanka,
Your
intake
voice
please.
is bit breaking,
in,
ma'am.
I cannot. Can you hear now?
Yeah,
Yeah,
better.
it's better. I'll introduce
Okay.
later
Okay,
Dr.
I'll comment
Priyanka. She is
later.
a
Okay. Yeah,
consultant
yeah, yeah. Okay.
pediatric gastroenterologist.
Done, done, done,
Priyanka,
done.
please, ma'am.
Okay.
Yes, ma'am. Dr.
Yes,
Priyanka,
Dr. Priyanka, please ask the question.
your voice is not coming, Dr. Priyanka. You can ask your query.
Acid levels and in lifestyle medicine you're on. Yeah, yeah.
Yeah, you go ahead, ma'am.
Ma'am, you
Okay.
take over. I think I'm not audible, so better you
No, no,
Yes,
now
yes.
okay. Now okay, ma'am. Now okay,
Now
you can
we
go
can
ahead.
hear you. Please.
We can hear you, please.
So I was saying that dietary practices affects the uric acid levels, especially the easy carbohydrate index. If
Okay.
we are eating a lot of high glycemic index food, it
Uh,
affects through the biochemistry pathways. So if
uh,
we reduce high glycemic index foods, it
uh.
changes the uric acid levels. That's what I was just.
Wonderful.
Okay, that can be one of the what you say factors, or maybe one of the alternative methods which can be
Yes,
helpful. But
only in asymptomatic cases, yeah, you can
yes,
try.
and another thing, when you see the population globally, not only India but globally, patient adherence to low glycemic diet or patient adherence to
Difficult.
a very healthy diet is very less. You
Very,
cannot rely
very.
on that.
That's true.
Only what
Right.
two main things you can tell to the patient is avoidance of meat, that is your red meat, or as I said, low protein diet. A lean meat can be okay, but a low protein diet and alcohol should be stopped. Those are the two things which can help modestly in lowering the uric acid.
Great,
Yes,
ma'am.
ma'am. This especially in the Gulf countries,
Hmm.
diet is rich in uric acid.
Proteins.
So we
Yes,
yeah.
yes, right.
So we used to advise the diet control.
Yes, perfect.
especially
So
for high
then,
in the uric acid.
yes, Gulf countries people do eat beef, people do eat other red meat. So ask them to keep it on a very low scale. Instead, promote them for eating a leaner meat. Like you can ask them to eat chicken, or don't ask them to eat shellfish. Shellfish is something, again, it has a very high uric acid level, or sea fish.
Yes.
Okay, so
Yes, ma'am.
something like that. Any other doubts? I hope class, the topic of gout is clear now.
Very much clear.
Okay, perfect. So now let us move ahead with the next question. Dr. Anisha, can you volunteer for reading out this question for me?
Yes, ma'am, no problem.
Yeah.
A 55-year-old man with cirrhosis presents with confusion and flapping tremors. There
Hmm.
is no focal neurological deficit. What is the
Okay.
first line treatment? Rifaximin,
Hmm.
neomycin, lactulose, protein restriction, and metronidazole.
Okay. So please take 10 seconds and let us see what are the answers coming in. Now, let us see for the words. A 55-year-old man with cirrhosis, already underlying cirrhosis is there, and he's presenting with confusion, flapping tremor, no neurological deficit. So, first line treatment. So, what is this case of exactly? This can be a case of what? And what will be your treatment? So, let me see the answers on the chat box. Okay, perfect. Everyone is very smart. The correct answer for this has to be lactulose because this is a case of hepatic encephalopathy. Okay, fine. And the buzzwords here that we
Grade 1.
would like to say
But
is
ग्रेड वन हो गया ना अभी
55-year-old man with underlying cirrhosis, confusion, flapping tremors, or asterix, what you call it as, and no focal neurological deficit. Okay, so these are the main words that we see here. And let us move ahead that why lactulose is a condition that we choose. Sorry, it is a treatment option that we choose. So cirrhosis with confusion asterisk can sometimes be one of the thing which is given, but here there is no focal neurological deficit, but there is confusion. Okay. So hepatic encephalopathy is what? It is a neuropsychiatric presentation which generally is caused by it is generally caused by the accumulations of neurotoxins, mainly you can say ammonia. And this ammonia, it gets accumulated, it affects your brain, which is the main reason that you get this confusions. And it can be due to the portosystemic shunting. So whenever you think of hepatic encephalopathy, always remember these three things. First is what? It is a neuropsychiatric condition. So although being a liver related disease, it can cause you neuropsychiatric condition. Second, it has to be due to accumulation of neurotoxin. Now, when I say neurotoxin, the main thing has to be ammonia. Okay. And this is a failure due to portosystemic shunting. Now, when you say that portocaval anastomosis, so portocaval systemic shunting that gets stopped, and due to this what happens, all the toxins they enter or they cross your blood brain barrier. Now once they cross your blood brain barrier, they can cause you the cerebral edema. So whenever this there is going to be portocaval shunting, this is going to cross your blood brain barrier, and then it is going to cause you cerebral edema as well. So this is basically the pathophysiology of your hepatic encephalopathy. So many of the times students have a confusion that although the presentation is hepatic, why there is CNS involvement in this? So the basic answer for this is neuropsychiatric condition with accumulation of neurotoxins, that is ammonia, and they get connected with your astrocytes inside your brain. They cross your blood brain barrier, and due to the connection with the astrocytes, they give you cerebral edema, and this causes you hepatic encephalopathy. Okay, so now the treatment that you will give in the first line treatment of hepatic encephalopathy has to be lactulose, Now, why lactulose? Because it is caused by accumulation of ammonia, and lactulose reduces the ammonia absorption from the gut. So, lactulose acts as a barrier. Okay. So, whenever there is going to be a lot of lactulose, the ammonia absorption from the gut is suddenly reduced, and therefore we give this as the first line treatment for overt hepatic encephalopathy. Now, what does this word overt means and what this word minimal means? Now, let us see the difference between overt and minimal hepatic encephalopathy. First is the consciousness, that is your CNS related symptom again. In minimal hepatic encephalopathy, it is going to be normal, but in overt HE, it has to be altered. So, CNS symptoms related to the consciousness will be the first part in your overt HE. That is one difference which you should always know. Asterix, what you also call it as flapping tremors. Now, when we talk about asterix, it is not present in minimal, but it is present in your overt HE. That is the patient that we have here is a patient of overt HE. He already has altered consciousness. He has asterix or flapping tremors that is present. Now, treatment here, oh sorry, mild ammonia will be mildly raised, but ammonia is very highly raised. Normal ammonia values, what are they? It is going to be 15 to 45 micrograms per dl. Okay. Okay. So ammonia will be mildly raised and ammonia will be highly raised. Treatment lactulose here also treatment is lactulose here too. But in overt HE, lactulose is the only drug that can be given. And generally in the exam they ask you that whether overt HE patient or a minimal HE patient. Generally the patient has to be a overt HE only, because whenever CNS symptoms are present, whenever the ammonia values, if they are mentioned, very good, or if they are not mentioned, just analyze the CNS status, then you can understand whether the ammonia is normal or whether the ammonia is high. So whenever there is a patient of hepatic encephalopathy, see for the CNS status, see for the flapping tremors, then immediately tick your answer as lactulose. Now, what can be the causes for hepatic encephalopathy, or you can say the precipitating factors for HE? Basically, your overt HE. Okay. So, GI bleed will be the first thing, because it is going to increase the nitrogen load in the body overall. Infections, constipation, hypokalemia. Constipation, why? Because constipation can increase the ammonia absorption due to slow gut motility. So there will be accumulation of the products into the gut and it is not getting excreted. Therefore, it is going to have more and more ammonia, and more ammonia is absorbed by the body. Also, hypokalemia, which has an increased renal ammonia, sedatives, which is causing you CNS depression. Some people are used for taking sedative pills while sleeping. That time it can also trigger your hepatic encephalopathy. And yes, dehydration. Dehydration is one of the very common factors, especially in the Gulf regions. You will see that majority of the time patients do not have adequate intake of water. So dehydration can also reduce the clearance of ammonia. Now, treatment with the drugs. What is it? First, you have to give lactulose. The dose is always very high. It has to be 20 to 30 ml per orally every 1 to 2 hours until you see bowel movement. Once you see a bowel movement, then you can have titrating the dose to a lower value. Okay. So how much you have to give? 30 ml, maybe the dose you're giving 30 ml, for example. 30 ml at 2 p.m., 30 ml at 4 p.m., 30 ml at 6 p.m. But the patient is getting motion at 10 p.m. Therefore, till 10 p.m., you will keep giving 30 ml of lactulose. Don't worry, even if you have to give it at a higher dose, it is very safe to be given. Okay. After that, another drug that you can add here can be your rifaximin, or you can give neomycin, or you can give metronidazole. Metronidazole has a better anaerobic coverage. So, metronidazole is generally preferred in our regular practice. Rifaximin, yes, because majority of the patients these days, rifaximin is very used, but they are not showing a good safety profile with rifaximin. Next, nutritional management. Do not severely restrict the protein. As you all know that the ammonia is a byproduct from the nitrogenous waste that is coming. So do not restrict the protein completely. Recommended protein has to be 1 to 1.5 grams per kg per day. But you can also give it in the fashion of 0.75 gram or 0.5 gram per kg per day. Because this is what we practice here, we follow. But recommended can be between 1 to 1.5 gram per kg per day. So for example, if the weight of the patient is 80 kg, how much of protein can you ask him to take in the day? Yes, anyone?
80 to 120 grams.
Yes, very good. So generally we'll ask the total 24-hour intake. Okay, it's not that one meal intake. It is 24-hour intake. You can ask from 80 to 120 or 130 grams of protein in a day. Now prefer vegetable and dairy protein. Why? Because it is a clean and a lean protein. Meat protein is to be avoided. So ask the patient to take maybe curds, soy, tofu, whatever is available as a vegetable and a dairy protein. Now what majority of the time it is there that patients you will confuse while treating the patients. First you're giving rifaximin and you're forgetting lactulose. So don't do that. Lactulose with rifaximin or lactulose with metronidazole or lactulose with neomycin is indicated. Then restricting protein aggressively, this can cause your cachexia, that is your muscle wastage. Already there is cachexia in the liver failure patients, so do not restrict the protein aggressively. Treating ammonia level instead of the clinical picture. See, first you treat the ammonia levels just to get rid of the encephalopathy. Once you get rid of the encephalopathy, then treat the underlying cause. Then treat the underlying cause, that why is this patient having this picture? Why was the reason for hepatic encephalopathy? And forgetting to titrate the lactulose. Okay, fine. So this was all about your hepatic encephalopathy. So there is how many grades? 1, 2, 3 and 4, which comes in your overt HE that we discussed right now. And minimal HE is just 1 grade. That is your minimal HE. Okay. And in overt HE, there are going to be 4 grades of your hepatic encephalopathy. So any questions anyone has about hepatic encephalopathy? Yes, you can
No,
ask me the questions for hepatic encephalopathy,
no
please.
problem. All good.
Okay, sir. We can go ahead.
Yes, yes.
Okay. All right. Now, the next question. A 42-year-old man has persistent hypertension despite being on 3 antihypertensive drugs, including a diuretic. Serum potassium is 3.9 milliequimoles per liter. There is no family history of hypertension. The most common cause of secondary hypertension overall is first, primary aldosteronism, renal artery stenosis, chronic kidney disease, pheochromocytoma, or Cushing's syndrome. So just take 10 seconds. Try to answer this question. Okay, I have already started getting answers. Yes, everyone, actively please try to answer. Although you're wrong, not a problem. You can anytime try that. Okay, Dr. Jay is saying CKD. Dr. Savita is saying pheochromocytoma. Yes.
CKD, ma'am.
Dr. Deepika is saying CKD. Okay. Okay. Fine. So now, yes, Dr. Anil is saying pheochromocytoma. All right. So let us come for the discussion. Firstly, what is the question that they are trying to ask you? So it has to be what? It has to be a persistent hypertension. Although we know that the patient is having hypertension from before. So persistent hypertension, 3 antihypertensive drugs. So ABC, maybe whatever the 3 hypertensive drugs, it also has a diuretic. AS, ARB, diuretic, something or the other is given. Potassiums are 3.9, which is raised. No family history, which is normal, sorry. No family history of hypertension, and most common cause of secondary hypertension overall. So basically they are trying to ask you a mixed question. And here, majority of the options is given related to your endocrine. They are trying to confuse you. Okay. So always remember, just one line, secondary hypertension cause overall has to be your chronic kidney disease, nothing else than that. Okay? Yes. So CKD is the right answer. Don't get confused with the options. Generally, they give you all the options related to the endocrine and the word secondary hypertension. Okay. But the main answer here has to be the most common cause. Yes, CKD. Right. Very good. Has to be CKD. Now, why CKD will be the most common cause of hypertension? That is the secondary hypertension. Why in CKD? What do you mean by CKD? CKD means your renal parenchymal disease. So, everyone knows what is the renal parenchyma. So, whenever there is any problem with the renal parenchyma, we say that it is the secondary hypertension, or we can call it as the CKD. Now, this CKD can be due to various mechanisms that gets activated. First, the foremost is going to be a RAS activation, renin-angiotensin system. I guess in my classes, I have already explained very well what is renin-angiotensin system, how is getting activated from the lung to the liver and then to the kidneys. Okay. Then we have your sodium and water retention. So sodium and water retention. Always have this one thing in your mind. Wherever sodium goes, water follows. Or wherever water goes, sodium follows. So they are just like a couple. They go hand in hand, sodium and water. So it can never be only sodium retention and it cannot be only water retention. It has to be sodium and water retention togetherly. Okay. And then there is the sympathetic overactivity. So there are three things. One is renin-angiotensin, one is sodium water retention, and then you have your sympathetic overactivity. Now, whenever the sympathetic system is getting overly active from the adrenals or the hormones which are released from the adrenals, then it can cause you CKD. Okay. Now let us see the explanation.
Mama, can you get headphones from my room, please? Headphones, viva headphones. What? iPhone.
Okay. So chronic kidney disease, the answer is right because it causes sodium water retention, renin-angiotensin system, and endocrine causes are not important. Why? Because it doesn't cause you secondary hypertension. Now, whenever we have the causes of secondary hypertension, I would just like you to remember what is the system and what is the cause. Only two things. And the clues here, you can just go through this table later. But once I am saying that it has to be renal, it has to be due to the CKD, and which is the most common. Then when you talk about renovascular, that is your renal artery stenosis. Renal artery stenosis, it is going to be there, but only if they mention that there is the presence of renal bruit, or whenever there is a presence of renal vascular bruit, that time you can call it as a renal artery stenosis induced secondary hypertension. In endocrinal, primary aldosteronism can be the cause. Why? Because of the overt sympathetic activity. Whenever the aldosterone is going to be high, there is going to be high sympathetic activity. Endocrine, as everyone knows, everyone is aware what is a pheochromocytoma. It is a rare adrenal gland tumor, and it has to have the triad. It has to have the triad of episodic headache, sweatings, okay, and your tachycardia. This word is missing here. So episodic headache, sweating, and tachycardia has to be there. Then you have Cushing's syndrome, which is also rare, not that related. Sleep related apnea, okay, can be the common cause. So these days it is very common, sleep related apnea. due to the stress, due to the night shifts, or maybe due to the overweight, sleep-related obstructive apnea is getting more common. And drug-induced too much use of NSAIDs or OC pills for a longer period of time. So there are 4 important factors that you need to know. First is renal, then renovascular, endocrine, only aldosterone related, and sleep and drug induced. So these are the causes for secondary hypertension overall. Now, let us skip directly to the renal parenchymal disease. Renal parenchymal disease, which is in connection with our CKD or with the answer right now. As we know that whenever we say that it is a renal parenchymal disease, the serum creat has to be more than 1.2. So sometimes the serum creat can be 2, it can be 3, it can be 6. Okay. Can anyone tell me out of this, when do you indicate a dialysis? What should be the serum creat level to indicate dialysis?
It's more than 3 with raised potassium level.
Okay, what you're saying, it has to be more than 3. Okay, any other answers?
More
I
than 6
think there
gram
is
per
no.
mg per dl, ma'am.
More than?
6.
Okay, Dr. Indu is saying 6.
Yes,
Okay,
ma'am.
anything else?
I think it depends on the clinical picture.
Okay. Yes, Dr. Rizvi, you are right. It depends on clinical picture. But if you have to see the lab figures, it has to be more than 5.5 plus your clinical picture. Okay?
Okay. Yes,
Yes.
thank you.
Yeah. So 5.5 creatinine, ideal indication for getting a dialysis, and plus your clinical sign symptoms, whether there is kidney shutdown or the kidneys are functioning well or whatever it is, you have to check the
Ma'am,
clinical
one more
picture.
thing. Sorry
Yes.
to disturb, ma'am. If there is no clinical manifestation like a severe one, and
Hmm.
the creatinine is higher than 5.5, still we can go for dialysis.
Yes, still we can go for dialysis, but again, here you will take the opinion of a super specialty, that is your nephrologist.
Okay. Thank you.
Yes. So we were talking about renal parenchymal disease. We have known the mechanism of how does this renal parenchymal disease come place. And when we see for renal parenchymal disease, we have to check for serum creatinine. We have to see for eGFR, that is estimated GFR, which has to be more than 90. And then there is urinary proteins, which has to be less than 150. These are the normal values. Something which is going above this and plus the renal parenchymal disease, always go ahead with the secondary management of hypertension. Okay. Now, there are some drugs which can cause you drug-induced hypertension. What these drugs are? These are going to be your NSAIDs, oral contraceptives, steroids, and decongestant. So, at times, this nasal decongestants that patients are taking, oxymetazoline, okay, these drugs can also cause you hypertension. Steroids and oral contraceptive, everyone knows that is a GYNEC part, but still everyone knows that estrogen is going to cause the activation of renin angiotensin system, and sodium water retention is very high due to your NSAIDs, right? Okay. So see here, this is a beautiful picture which shows your renovascular cause, that is your renal artery stenosis. It can lead you to the sound, that is the renal bruit, can be heard with the bell of the stethoscope. Then here on the CT scan, we see diffuse renal parenchyma. See this is the kidney. And here, look at the parenchyma. Look at the parenchyma here. It is all affected. This is a CT scan, USG image, which is showing you diffuse renal parenchyma. Any more questions? Any doubts anyone has on this?
Mute Dr. Kalai. You can mute your mic, please.
Yeah,
Yes, go
I
ahead.
have muted, sir. Yeah. Anyone has questions on CKD, please?
I think you clarify everything well. Hypertension and diabetes is the leading cause of chronic renal failure, isn't it?
Yes, sir. Very well said. It is the leading cause now, and India is getting the diabetic capital of the world.
True. Sad news.
Yes. Okay. So, sir, am I able to take one more question? The last
Yes,
question
yes, you
for now?
can take. Yeah, you can take. Then we'll
Okay.
carry on.
Yes.
No worries here.
Okay. And
People
then
would like to hear you more than me.
Yes. Thank you. Thank you, sir. No,
It's
we have
getting
your
interesting.
class.
No, no,
Yes, we
that's
have
fine.
your class also.
They listen me many times, so I'm here for learning. So I'm listening all your the
Okay.
important tips which may help in my practice. So I'm good student. Carry on. One more.
Thank you. Thank you so much, sir, for the motivation. Okay. So now coming ahead for the next question, I hope everyone is attentive. A 74-year-old man presents with resting tremor, rigidity, bradykinesia, and postural instability. Mild cognitive impairment is present. The best initial pharmacological therapy. Pramipexole, trihexylphenadinyl, levodopa plus carbidopa, salicylic, and amantadine. So I guess looking at the options and looking at a question looks very simple question for all of you.
Levodopa, ma'am.
Okay, perfect. And the cases of what? It's Parkinsonism. Okay, very
Parkinson's.
good. Yes, so everyone's very smart students out here. We have a case of Parkinsonism. The main words that you should be remembering for Parkinsonism is going to be the resting tremors. Okay, so when I say that there is going to be 1 minute. Yes, so resting tremors, rigidity can be of your cogwheel type. In Parkinsonism, there is cogwheel rigidity, bradykinesia, postural instability. Can anyone tell me what is bradykinesia?
Slow body movement.
Some slow movements or
Yes,
very
right.
slow.
Yes, okay. So slow movements is bradykinesia. Okay. Then postural instability and mild cognitive impairment. The correct answer for this is levodopa plus carbidopa because it is a case of Parkinsonism. Now let us see the explanation. So it is levodopa and carbidopa. Elderly patients has the maximum
Ma'am, can
symptomatic
you please
benefit.
mute? Like, it's very disturbing.
I have mute. Okay. See, someone's mic becomes unmute in between and
Ma'am,
I
please.
Is it okay now?
Yes, okay now,
Yes,
ma'am.
ma'am.
Go
Thank you
ahead.
so much.
Okay.
Yes, ma'am.
So, elderly patients now they need maximum symptomatic benefit. See, always remember in elderly patients, Parkinson is caused due to the substantia nigra depletion. Now, you cannot go and fix that substantia nigra in a 65-year-old or a 70-year-old patient. But what the maximum you can do for him is what? You have to benefit him symptomatically. So, therefore, levodopa gives the best motor improvement. Keep this in mind. This one drug, that is levodopa, is going to cause the best motor improvement. That is your bradykinesia can be very well be improved with the help of levodopa. Dopamine agonist and anticholinergics, they can cause sometimes hallucination and confusions also in the elderly. So first foremost, the first line management has to be your levodopa plus carbidopa. Can anyone tell me why do we use levodopa and carbidopa togetherly? What is the pharmacological basis of using this together?
Ma'am, levodopa easily crosses the blood-brain barrier,
Okay.
and I'm not sure if I'm right, but then carbidopa is used so that the time in the blood, it,
Okay,
sorry.
fine. You are attempting, right? But the thing is that it can cross the blood-brain barrier, no doubt. But it is used in the combination why to enhance each other's benefit. So, what you can say that one drug is enhancing another's mechanism. 1 minute, there's some network issue here. Okay. So basically, levodopa is going to levodopa and carbidopa. Carbidopa enhances the absorption and the stability of this levodopa drug, and they cross the blood-brain barrier. Therefore, we use it as the first line, the combination of levodopa and carbidopa. Then you have the dopamine agonist. Dopamine agonist is going to be your pramiprazole, which we generally avoid. But along with this, if you ask me the third drug that I can give with levodopa and carbidopa, can be your entacapone. Okay, these days it is very widely used in the daily regular practice also. So entacapone, levodopa, carbidopa can be very safely used. See, levodopa, carbidopa, levodopa is 100, carbidopa is 25, given 3 times daily, start low and then titrate. Now, one thing remember while treating the Parkinson patients, the timing of the drugs should be regular. The reason is we are giving hormonal drugs externally, that is levodopa and carbidopa. Once they get depleted from the body, the patient starts showing symptoms. For example, if the patient's timing is of 2 o'clock and the patient forgets to take the drug, he takes it by 6 o'clock, 7 o'clock. Immediately you can see the effects that he will have bradykinesia. Immediately there is going to be tremors. So the timing should be very fixed and it should be regular. Okay. Then you have pramiprazole. It is given 0.125 mg 3 times a day, but we do not give in elderly. Why? Because there is a risk of hallucination. Elderly people, we don't want them to hallucinate. So hallucination is the risk with the help of pramiprazole. Avoid it. Then you have trihexylphenidylin and selegiline. Selegiline causes MAO reaction. So, or your also can cause you cheese reaction, what you call it as. So this can also be one of the times one-liners that they ask you in exam. MAO inhibitors, cheese reaction is with the help of selegiline. So try avoiding selegiline. Instead, you can give entacapone. Now, what are the motor complications that a Parkinson patient presents? He presents you with the wearing off effect. That is what wearing off effect is. Shorter duration of benefit. Wearing off whenever the drug is wearing off from the body. Okay. And at times there can be on and off or dyskinesia. On and off. Why? Because unpredictable response. Sometimes the timing of the patient of taking the drug is gone up and down. He can show you sometimes he's very hyperactive, sometimes he's in a very low mode or a low state or very slow and sluggish. That is your on and off phenomena. That is generally seen with levodopa, carbidopa after almost 1 year to 2 years of treatment. Then you have dyskinesia. Sometimes the brain doesn't function as per we are giving the dose of levodopa, carbidopa. The moment you see that there is excessive involuntary movements of the patient, try to adjust your dose or try to change the drug. So that is a best indicator that you need to adjust the dose or change the drug for Parkinsonism. Now, what can be the add-on therapy? As I told you that entacapone is the best drug which you can give with levodopa, carbidopa, 200 milligram per oral once daily with levodopa. Okay. Motor fluctuations are there, that if there is a dyskinesia or there is a on and on effect, then you can give rasagiline. It belongs to the same category of selegiline. Rasagiline can be given 1 milligram per orally daily. That is also given once a day. Okay. Now, sometimes you can get wrong is what? Dopamine agonist not given in elderly. Keep this in mind always. Anticholinergic for tremors in elderly, we cannot give that. Antisecretory or anticholinergic drug for tremors, do not give it in elderly. Avoiding levodopa to fear dyskinesia. Why? Because levodopa with entacapone cannot give you dyskinesia. So this is the third point is explained here. That is your wearing off effect. Whose mic is this? 1 minute. Okay. Then you have treating Parkinson in the young onset patient. That is going to be Parkinson disease with Lewy bodies. It can be seen in dementia. Treating Parkinson like young onset Parkinsonism. First line you can start with entacapone in young patient. Young patient coming to you need not be giving levodopa, carbidopa. You can give entacapone plus levodopa. Okay. Adding antipsychotics indiscriminately can aggravate your Parkinsonism. So do not add any antipsychotics. Only safer antipsychotics can be your SSRI, or you can give something like clonazepam, which can be very well given. Yes, someone has any doubts? Let me check the chat box. Young patient mean that is occurring in 20s and 30s. Yes. Young patient means someone who is below 40 for Parkinsonism. Okay. Next, see this. This is basically an image which is showing your nigrostriatal pathway, and this is your putamen complex plus substantia nigra, which is intact in a normal patient. But here, look here in this image, look at the depletion, look at the bad state of the substantia nigra. And due to this depletion of the substantia nigra, this is going to cause the problem in the nigrostriatal pathway, leading you to Parkinson's disease. Okay. Yes. So I guess Parkinson was clear for all of you.
Yes, ma'am.
Yes, ma'am.
Any doubts
Yes, ma'am.
anyone has?
No, ma'am.
Okay.
Yes, ma'am.
Hello,
Yes,
Dr.
ma'am.
Munjal sir, are you there?
Yes, yes, I'm here. Yes, madam. I'm absolutely
Yes,
ready
sir.
to go
So I guess
with full
this was
energy.
enough for today. Yes, it was enough for
Wonderful.
today from my
Lots
end.
of learning. Non-oncological, lot of learning.
Yes, yes. Thank you
It's
so much, sir.
required
It
for
was
me.
all your motivation. And I hope students had a very enjoyable session. I have a lot of other MCQs as well, but due to the constricting time, I cannot take it today. Next session will surely take another MCQs.
Wonderful, wonderful. Thank
Thank
you.
you, ma'am.
Thank
Thank
you,
you so
ma'am.
much.
I
Excellent
want
lecture.
Thank you,
everyone
ma'am.
to
Thank you very much.
I want everyone to at least post the some feedback in the group or so, right? You understand, right?
Yes,
While you are
students. And
taking, yeah,
sir,
yes,
1 minute,
please.
sorry to disturb you. But
Not
also,
at
they
all.
can add up their own inputs, not necessarily being only positive. You can give your
Yes,
suggestions that what we can include in the sessions. That also we will
exactly,
be taking care of.
exactly, exactly. So that is more important, the feedback as well as suggestions, not just the feedback. And every feedback is like a learning for us to improve and go to the next level of the coaching. Wonderful. But it is like undoubtedly super brilliant.
Thank you.
Very
Thank you
much.
so much, sir. Thank you, class.
Wonderful. Yes.
Yes, sir.
If can you make ma'am make me admin if possible?
Yes, 1 minute, sir. I am a bit technically challenged. I'll try to do that.
No, no. What you can do on the on my name, click on my name on the right side. There are three horizontal dot. Make me
Yes,
host.
right.
That's it.
Make host. Okay.
Wonderful. I also become little IT guy.
Thank you, sir. Yes.
Yeah.
Over to you, Dr. Munjal Pandya, sir. I am signing off.
Wonderful. Thank you.
Yes.
Wonderful.
Yeah.
You
Thank you,
also
ma'am.
can participate if you have time and give all your suggestions as well, how I can improve my
Yes, yes, sir.
class.
I'm attending the lecture. I'm very well here, but I'm just muting myself.
No problem. So
Yeah.
your comment and feedback would be highly appreciated. Great, wonderful. So thank you very much once again. I get a lot of motivation from Dr. Akanksha now. So probably I would try my level best to deliver best of my best today. So without wasting the time, that's it. First question in front of your screen. Which vaccine is contraindicated in pregnancy? It is TD, hepatitis B, influenza, or MMR. There are a lot of questions I posted here. What are the questions? Which category of vaccines are contraindicated in pregnancy? Number one. Number two, list of the vaccines that are absolutely contraindicated during pregnancy. Question number two. Three,
Three.
The
what is the
screen is
reason
not
for
visible,
contra?
sir. Hello,
Sorry,
sir.
ma'am.
Screen is not visible.
Sir,
Like
your
the
screen is
questions are
not
not
One
shared.
visible.
1 minute, 1 minute. I'm going very quickly, but sorry, sorry for that. Now let me know if it is visible or not. Is that okay now?
Yes,
Yeah.
yes, sir.
So, okay, sir.
Wonderful. So
Thank you.
this is the first question. Which vaccine is contraindicated in pregnancy? TD, hepatitis B, influenza, MMR. So there are a lot of questions in the one question. There are a lot of other questions. So first is which category of vaccines are contraindicated in pregnancy? right? That is one thing, right? Second question is list of the vaccine that are absolutely contraindicated. Third is which, what is the reason for contraindication? We must know, right? We are reading for quite long. These are the contraindication, but why? What's the reason? Which vaccines are safe and recommended during pregnancy? And if the contraindicated vaccine is given accidentally, what you supposed to do in that case, right? It is a contraindicated, but somehow by mistake somebody has delivered. What is the thing? So first, let me ask you the first question: which vaccine is contraindicated in pregnancy? Right. So give your answer in the chat box. Then we can discuss as usual. Right. So then we'll solve all the queries and questions given here in the box. Yes, please. Wonderful. So majority of the house is going with the MMR, and there is no doubt of MMR. So that's it. That's perfect. So let's see the total understanding of this question. So category is contraindicated in pregnancy. So in general, any vaccine which is live vaccine, right? Live vaccine is contraindicated. So category contraindicated in pregnancy. So you just need to know what are the live vaccines are there, right? Vaccines contraindicated in pregnancy means no live vaccine in pregnancy that are contraindication in pregnancy. So let's see the little list of the things what we would like to remember in a clinical practice. It is absolutely a clinical question. So vaccine contraindicated in pregnancy, that are the live vaccines, right? So vaccines MMR, right? And you need to know the reason, right? Vaccine contraindicated. This is the name of the vaccine. Why you want to avoid it in pregnancy? So MMR stands for measles, mumps, rubella, risk of congenital infections, varicella, congenital varicella syndrome, right? BCG, live mycobacterium, OPV, oral polio virus. There is killed vaccine is available, right? Oral polio vaccine live and killed is also now available. So oral live vaccines you can avoid live influenza and yellow fever, live virus and live typhoid, live bacteria. So key exam answer is MMR and varicella. This is the most important one amongst the list, right? So you need to know what vaccines are contraindicated in this pregnancy. So this is the list of the vaccine. Now we'll go all the questions, right? So what we have seen so far is like, right? One is live vaccines. Which category is contraindicated? Live. What are the name of the vaccines, right? So we know now that. Third, reason for contraindication. I guess probably few doctors doesn't know what is the reason why it's contraindicated. So live attenuated organism can, they can cross the placenta, right? They can cause the fetal infections and it may lead to a teratogenicity, and fetus has an immature immune system like bone marrow and neutrophil and lymphocyte and humoral and cell mediated immunity. We probably cover in some time of our hematology lecture. So this is the reason, right? So live vaccine, they can easily cross the placenta, go to the fetoplacental route to a baby, fetal infections, and probably it's one of the bad is a teratogenicity. So that is why it is contraindicated, or this is the reason why you supposed to avoid it. And vaccine safe in pregnancy, that is, so any questions they ask, contraindication, indication, which use, don't use, so all everything is explained here very well. So vaccine safe in pregnancy, TD, routine protects against neonatal tetanus and pertussis. So you must be knowing, right, at the 7 week, 7 trimester and probably 8 and a half, gynecologist knows better, but there are two vaccines of tetanus they are giving into the pregnant woman, right, 1 month apart overall, right? So that gives the protection to the baby as well, right? So inactivated influenza vaccine can be given at any trimester. Hepatitis B, if risk is present, you must give it. COVID-19 all trimester, it is now recommended. Rabies vaccine post exposure usually, right? So post exposure, post dog bite, there is a risk of rabies. So 0, 3, 17, 14, and optional fifth dose 30. That they sometimes ask you what is the schedule of rabies virus. So you must know the post exposure rabies, this vaccine schedule. Inactivated polio, as I told you, if needed, you can use it. Then typhoid, right? If the patient has very high risk or endemic or very high risk of typhoid areas, there you can also give safely in the pregnancy. So these are the vaccines can be delivered safely in the pregnancy. So lastly, if contraindicated vaccine given accidentally, right? These are our 5, 6 questions, right? So we covered it 1, 2, 3, 4, 5, 6, right? So we have seen contraindicated, we have seen, right, what is the reason for contraindication, which are the safe, and lastly, if someone can give the accidentally the vaccine, if contraindicated vaccine given accidentally, what you supposed to do? Not an indication of abortion. So if somebody has given the live vaccine, say for example, live vaccine in pregnancy, had given what, you don't need to do abortion, right? You need to just reassure the patient. You need to do routine antenatal follow-up with the anomaly scan, because it is a teratogenic, what we have recently seen, and you should report and document it properly for medical legal purpose. So that's all for this thing. And favorite one-liner favorite questions: live vaccines are contraindicated in pregnancy. MMR and varicella must be avoided in the pregnancy. Inadvertent vaccination is not an indication of termination of pregnancy or abortion, and Tdap is recommended in every pregnancy. So that's all from my side. I think it's very much clear cut. So we'll proceed to the next question. Though it is a very
Sir,
simple question,
I
but
have a
lots of
question
question. Yes, please, you can ask the question.
regarding.
Yes, please.
Sir, I want to ask in UAE setup, what vaccines are giving during pregnancy? In our setup, we give tetanus and hepatitis B.
Basically, honestly speaking, every country has their own vaccine schedule, right, as per the epidemiology and geographical areas. So I think we'll need to look into it, but this is the general guideline for all, irrespective of the countries. These are the vaccines included, these are the vaccines should be avoided, and the reason and why and all blah blah. So let me go through the some UAE guidelines if I can get right. I have few pediatricians there in UAE, so let me ask with them that what they exactly follow the things and what are the vaccine given in the pregnancy in UAE, right? So just keep check on me. So probably by day or two, I
Okay,
will
sir.
get back to you with the same question, right? So let's jump and move to the next question. 30-year
Thank
old
you, sir.
woman is 6 weeks. You're welcome. 30 years old woman is 6 weeks postpartum and breastfeeding. She wants contraception. 30 years, quite young, 6 weeks postpartum,
The distribution
right?
of
And
disease
breastfeeding.
from
What is the best option for the contraception for them? What is the best option for contraception for them?
The
I
progesterone.
muted all to just avoid the disturbance, so you can unmute when you want to interact. So combined oral contraceptive pills, progesterone only pills, copper IUCD, or emergency contraception, right? So what exactly you use, and I want to know why you selected that option. That is more important and interesting to understand. So you can answer or post your answer in the chat box. So I'm seeing, see, yes, Rabia. So let me open the mic for you. Why you want to use the copper IUCD? Why you don't want to use something non-invasive or some progesterone only pills? Is there any reason, doctor? Yes, Dr.
Sir,
Rabia.
because patient is
What's your
already on
concern?
breastfeeding, I don't
Okay,
want
fine.
to create the hormonal disturbance.
Okay, so if say by example, if you give the
So that's
progesterone
why I
only pills
choose.
to this patient, if you give the progesterone only pills to the patient, what happens wrong to the patient? Is it contraindicated postpartum or breastfeeding? What do you think? If somebody has
I have
given, say
no
for
exact
example,
idea
accidental, you
about
had given.
it, but
Fair enough, fair enough. That is why we are discussing all important and tricky MCQs, right? Right? Yes, Dr. Ishara. Any comment from your side, Dr. Anil Bisnoi?
Yes, sir. In a postpartum period, the mother is breastfeeding to the child. So, POP is the best because progesterone is not contraindicated in breastfeeding.
Wonderful, wonderful, wonderful. Let's go to the Dr. Savita. I think she is a gynecologist. So we would be happy to have a word and expert opinion from Dr. Savita. Yes, please.
The best answer is it doesn't have estrogen, sir.
Your voice is not there, doctor.
Okay, I
Absolutely
will
no
type,
voice.
sir. There is some problem, I will type, sir.
Fine, fine, fair enough. Right. So she is also telling the progesterone only pills, right? So that is the comment from the expert panelist, right, who is sitting in the class. So answer is a progesterone only pills. We'll
Sir,
decide why not, right? So our job is not just to get the idea why this is the answer. Every time, as you know, we dissect why this is the answer, why this not, why this not, why this not. We also want to know why we have not selected the copper IUCD or some other emergency. So let's see the explanation. So progesterone only, please. explanation is safe in breastfeeding. This patient is breastfeeding. It is given as right, postpartum and breastfeeding. Our patient is breastfeeding and first line safe in breastfeeding, does not reduces the milk production, important for the baby's feeding, right? So this is the two key major things. Option A, combined oral contraceptive pills, it reduces the estrogen, reduces the milk production, right? So avoid before 6 months. So it's very important because it reduces the milk production and we don't want to reduce the milk production. Baby is on best breastfeed. Copper IUCD can be used, but POP is the most exam preferred, right? And safe as well, right? And option D, emergency contraceptive, not for regular use. It should be used, right, in an emergency, right? So this is what the thing is. So you don't need to confuse yourself, right? So example, right? AUB more than 40 years, biopsy first, abnormal uterine bleeding, stable ectopic. These are the few questions, right? So there are 5, 6 questions. Examples, one line is one question, right? What you supposed to do in such case? So AUB more than 40, biopsy first. Stable ectopic, methotrexate first. Estrogen excess in child, granulosa cell tumor. Last time we seen it, this can cause the precocious puberty, right? Because of the excess, right? It is not the other ovarian tumors, right? So they ask you in the exam, right, which ovarian tumor can cause precocious puberty? Answer is granulosa cell tumor, not the other tumors, not the classical ovarian adenocarcinoma, not the serous, not the mucinous, granulosa cell tumor. Why? Because this tumor secrete the excess estrogen, and this excess estrogen is responsible for the precocious puberty. So answer is granulosa cell tumor, right? Endometrial thickness more than 4 millimeter, get the biopsy to rule out endometrial carcinoma. Breastfeeding, progesterone only. That's it. So this is what the take home message from my side in the last, right? So I will jump and switch to the next questions, right? So it is not that difficult, but we need to know the basic, right? So let's see. This is all my favorite subjects of hematology. Which type of von Willebrand disease is qualitative defect of von Willebrand factor? Understand the question. Which type of von Willebrand disease is qualitative defect of von Willebrand disease? That means type 1 is it a qualitative defect? Type 2 is a qualitative defect. Type 3 is a qualitative defect. Or acquired von Willebrand disease have qualitative defect in the von Willebrand factor. So what do you think? I mean, so what could be the answer? Number one. Then we'll dissect little more for all bleeding disorder and all little these things. And I want you to ask a lot of questions to me on this. Yes, post your answer in the chat box. So this is like almost all the questions are first time you probably see it. So you can assess yourself. Yes, please. I did not get any answer so far, right, from the chat box, though we are more than 40 doctors now at a time, and there is no 4 answers as well. Yes, yes. Anyone? Okay, this is new for me. Type 2, not sure. Yes, Jay. Any comment you would like to tell, Dr. Jay? Don't worry,
Sir,
right or wrong. Discuss it. That's it.
in type 2, I think there is an decrease, whereas in type in quantitative. Oh, sorry, type 2 is decrease in qualitative, whereas type 1 is decrease in partial quantitative.
Fair enough. Let's disagree. Yes, Dr. Khadija, what's your comment? Yes, Dr. Khadija,
Hello,
what do you
sir.
think? Yes, please.
Okay, sir, I know the type 3 is the one where it is most deficient.
Okay. Most deficient,
So,
qualitative.
qualitative, I think, is actually type 2, sir, not type 3.
Your
Type
answer
3 is
is
just the
3, so you
worst.
fix, decide. I'll give you the opportunity to change the answer. Probably
Type
that's
2,
not the
sir,
case in
type 2.
exam. Type
Type 2
2.
is
So now
qualitative.
can you tell me what is type 1 defect and type 2 defect, or what exactly there in the type 1 and type 3 defect?
Type
We
1
read
is
many
the
a time.
mildest form.
No, I am not asking the severity. What my question
Mm.
is, type 1 is qualitative or quantitative? Type 2 is qualitative or
Quantitative.
quantitative? Type 3 is qualitative or quantitative? I want to know that.
Type
Fine,
1
fair
is
enough.
quantitative.
Okay,
Type 2 is qualitative.
okay,
Type 3, I'm not sure, sir.
fair enough,
Quantity.
fair enough. So how do you get how you check the quality of the von Willebrand factor? To clot the blood, let me sorry, I'm like it's my subject, so I'm going bit in detail. So if you want to clot any blood in the body, you need a platelet. Without, so if you have thrombocytopenia, you have bleeding, right? If your von Willebrand factor missing or reduced, you have a bleeding. If your factor, right, factor deficiency or factor problem, right, factors are low, there is a bleeding. So how did you get to know that this is the missing part in the blood and which cause the bleeding? Say for example, I can say some patient present with the oral bleeding. It could be platelet, it could be von Willebrand, it could be factor. So how you supposed to differentiate, right? So let's go on that part as well, right? Along with this. So this is practical thing, right? So bleeding, every patient does not need a platelet factor. No? When the platelets are normal, how you supposed to control the bleeding? Platelets are normal, no logic giving the platelet. So we need to understand. So before jumping that, this is first the basic. I'll start type 1, type 2, type 3, right? So what is type 1, type 2, type 3? Just for your knowledge, this is the most common among this is the number one, first most common. Two means second most common. Type 3 is third most common or rare. And thank God it is rare because it is one of the worst. Type 3 is complete absence of von Willebrand disease. You have no choice, right? You have no choice that you can give the von Willebrand factor, right? Except von Willebrand factor infusion, you have no choice. You have no choice, right? So this is a quantitative problem, partial, mild problem. You can say mild. In terms of severity, you can say mild. Partial quantitative. This is complete quantitative, complete absence or complete quantitative. So you can say von Willebrand factor in plasma is zero or near zero. There is no von Willebrand factor, right? So 1 and 3 is a quantitative problem and 2 is a qualitative problem. Just for your knowledge, it's important for us to understand the pathology or simple things, right? Which will drive the total, the flow chart of the treatment, right? So so correct answer here is the B. What they are asking in our questions, right? Which of the von Willebrand disease is a qualitative defect, right? So qualitative, now you can see it, qualitative abnormalities type 2, not 1 and 3. They're quantitative means number. They are dealing with a number, right? So number is quantity, right? And quality is like function, right? So there is a problem in the functionality, right? That is called quality, right? So that is a two different word, right? So this is the answer for this, right? One A is a quantitative, right? C is a quantitative and secondary to other disease. So A, C, D, N is not the answer. Answer is the B, right? It is because of the poor quality of the von Willebrand factor. That is 2. So let's see little more detail, right? What is the treatment? What is the mechanism? What is the head-to-head comparison between all three? Because there are a lot of questions with the von Willebrand disease, right? I guess so, right? In hematology as well and many other exams. So this is a very quick brilliant chart here. I brought it for you guys. So type 1, as I told you, right? This is a qualitative problem. This is quantitative. This is quality problem, and this is quantity. Here, quantity is low. Here, quantity is completely absent. Here the quantity is okay, but quality is poor. That is the answer, type 2. So fortunately, mild variety is almost 70-80%. This is 20%, and it is extremely rare. It is good, extremely rare because it is a very bad. Worst form of von Willebrand is type 3, right? Defect, partial quantitative problem, complete quantitative problem. It's a qualitative problem. Inherited autosomal dominant. This is autosomal recessive. Von Willebrand factor reduced, right? Here, see normal. Why it is written normal? Because there is no problem in the quantity, amount of 1 Willebrand factor is normal in plasma, still they are bleeding, and in few occasions it is reduced as well. And here not reduced, completely absent, completely absent, and that is why complete absence, one of the worst form, no 1 Willebrand factor in plasma, no clotting. Forget about clotting. Patient is bleeding heavily, either nose bleed or gum bleed or hematuria or heavy menses, whatever the superficial platelet kind of bleeding, you will see each and everything in this patient. Factor 8 mildly reduced, factor 8 mildly reduced, here normal or mildly reduced, and here is markedly reduced. Why the factor is reduced, that is also again important point of discussion. Von Willebrand factor carries factor 8, so in this absence this cannot be utilized well, right? They are low in the plasma, right? And PT and APTT is also high, mainly the APTT, right? So the clinical features of blood workup, the most important thing in von Willebrand is bleeding time is increased. One of the most extremely important high yield point for the exam. So bleeding time is high, and another thing is PTT is high. PTT is high. If you know these two parameters, you can differentiate lots of condition. Example, hemophilia. What is the difference in hemophilia and von Willebrand disease? So in hemophilia, PTT will be increased, but bleeding time is normal. One of the biggest differentiating point. Take home message. So we'll discuss sometimes, right, in the next couple of slides, but just for you to know why this is low in von Willebrand big. This is a carrier of the von Willebrand factor 8 is a von Willebrand disease. They goes together, right? So this is the thing. Bleeding severity mild, this is mild form, this is moderate, this is severe. So worst one is the 3, as I told you, right? Typical bleeding, usually the superficial bleeding, epistaxis, menorrhagia, mucocutaneous, right? And type 3 is like bad one, which is usually seen with the hemarthrosis or hemophilia, factor 8 deficiency. Factor 8 deficiency, hemarthrosis means there is a lot of bleeding, bad bleeding in the joint, especially the knee joint. This is a classical presentation of hemophilia A or B. Mainly the 8 is more common than B, or factor 8 deficiency is more common than 9. So if factor 8 deficiency, it is hemophilia A. Hemophilia B is 9 deficiency, and hemophilia C is 11 deficiency, just for your knowledge, right? So PT is usually increase in all this. We'll see in the internal and external factor cascade or clotting cascade. I'll clarify all the thought process. Bleeding time, as you see, prolong. Absolutely, because von Willebrand factor is either qualitative or quantitative problem, does not get the blood clot, so bleeding time would be high. APTT, why high? Why high? Why high? Why high is because of the factor 8. Factor 8 is carried by the von Willebrand. Factor 8 activity is monitored by the PTT. So there is an intrinsic factor, extrinsic factor, right? So extrinsic factor, only one factor, right? So this is intrinsic factor and extrinsic. 7 is on the extrinsic pathway monitored by the prothrombin time. Intrinsic factor, I'll teach you very nicely. Factor 8, 9, 11, 12, here 2, 5, 10, here prothrombin to thrombin, and fibrinogen to fibrin. This is what I told you in just 15 seconds, complete clotting cascade. So this is extrinsic pathway, this is intrinsic pathway. Intrinsic pathway, there is factor 8, and factor 8, right, is intrinsic pathway is monitored by PTT, or intrinsic is monitored by PTT, and extrinsic monitored by PT, prothrombin time. So factor 8 is in intrinsic pathway monitored by PTT, and that is why the APTT would be high in most of the von Willebrand disease, right? DDAVP is a good response to the treatment type 1, right? What is a DDAVP, or it is called as a desmopressin? Desmopressin. What exactly the mechanism of action, right? This is endothelial factor, right? Vessel, this is endothelial cell. So from this cell, right, when you give the injections of DDAVP or desmopressin you give to the patient, it will release the von Willebrand factor from the endothelium, von Willebrand factor, right? So in mild category, it is a good treatment of choice. You just give the DDAVP or desmopressin injection to the patient. What it exactly does, it goes inside the body, right? It releases the von Willebrand factor from the endothelial cell, and it increases in the plasma, bleeding will be stopped, patient is fine. So this is a good response. Type 1, very poor response here, right? Because there is a problem in the right quality. Quantity is not a problem. There are a lot of von Willebrand factor in type 2, but whatever the factors are there, they are not working well, and that is why it is a quality problem. So by giving the DDAVP, it want a response, and here absolutely absent. So when there is a no 1 Willebrand factor in the body, whether whatever the desmopressin you give, nothing will release. Why? Because there is no zero, there is a no 1 Willebrand factor in the body, like type 1 diabetes, right? Type 1 diabetes, there is a no insulin at all in the body. What you need to do, you need to supplement the insulin. That's it. Here in type 3, there is no 1 Willebrand disease, any injection, any drug, any platelet, any blah blah, cryoprecipitate, fresh frozen plasma, nothing will going to help this patient, right, except transfusing the 1 Willebrand factor because it is completely absent. And treatment, as I told you, the DDAVP is in the mild category, desmopressin, here the 1 Willebrand factor concentrate now available in the market and for the same. And if you don't have this specific, the drug you can use or product, blood product you can use is cryoprecipitate. Remember, cryoprecipitate. Cryoprecipitate contains three things: 1 Willebrand factor it contains the factor 8 and it contains also fibrinogen. So whenever you want to use any of this, right, 1 Willebrand disease, you can use cryoprecipitate. Hemophilia in emergency, if you don't get any product like factor 8 recombinant injection, use the cryoprecipitate. In DIC, if you don't get anything of fibrinogen, you use it cryoprecipitate. Why? Because it contains all these three things inside the cryoprecipitate of 50 ml of bag. You just get it, you transmute it. That's all from my side for this type 1 and 2 and 3. So I tried my level best to make you understand how one differentiate from the other. So let me move my clock forward. So concluding my talk, treatment summary is type 1 mild desmopressin. This all are the one question. One line is one question. Believe me. So you cannot afford to miss any of the line. So type 1 desmopressin, right? It will not help in other conditions. Type 2, 1 Willebrand concentrate. Type 3, 1 Willebrand plus factor 8. Menorrhagia, DDAVP plus tranexamic acid. So this is symptomatic treatment. I have many patients in my OPD, those who have 1 Willebrand disease and excessive menstruating and blah blah. So we give the tranexamic acid and desmopressin. That's it, Kalas. Surgery, major, right? You need to use the 1 Willebrand concentrate only because you need to keep higher level of 1 Willebrand factor. Otherwise, there would be a lots of post-op bleeding and patient may end up with a hypovolemic or hemorrhagic shock and blah blah the rest condition. So last but not the least, examples, right? Type 1 most common, as I told you, 80 to 90% or 70 to 80%. Type 3, so if they ask you which one is the most common among type 1 2 3, answer will change. Type 1, they ask you which is the most dangerous among 1 2 3, most dangerous is type 3. DDABP works in type 1 2 3 only in 1, right? And menorrhagia as a symptomatic treatment, and that's it. So this is all the high yield all for you to know for the 1 Willebrand disease. So I would be glad to answer you more questions or queries on the von Willebrand. If you have any, I would be happy to answer you any of your random questions related with this or any other questions related with the bleeding. I'll give you 10 seconds. Think of it, ask me, otherwise I'll go ahead. No questions? Yes or no? At least reply. No questions? Yes or no?
No, sir.
No, sir.
Wonderful. That means I did my job
No
good.
question.
Wonderful. Indirectly. Great. Wonderful. So don't miss out now. Now change your gear from gynec to hematology. Now hematology to respiratory. 68-year-old man with a known case of COPD, chronic obstructive pulmonary disease, presented with a worsening dyspnea, wheeze, and drowsiness. On examination, respiratory rate is 30 per minute, SpO2 is 86%, on room air, ABG on 24%, Venturi mark shows. Right, so this patient is 68 years, known COPD, presented with the respiratory symptoms, and the vitals shows respiratory rate is 30, obviously high. SpO2 is 86, on room air obviously low. He is now on the and ABG on 24%. Venturi mark shows. This is the ABG. What ABG shows? pH 7.28, PaCO2 68, PaO2 55, HCO3 is 30 millimole per liter. What is the best next management or what is the best next step in the management of this patient? Increase oxygen to 60% via face mask instead of 24%. Immediate endotracheal intubation for this patient. Start non-invasive ventilation for this patient or BiPAP, you can say. IV sodium bicarbonate infusion you can give for these patients. Probably you think it is acidosis, so I need to treat it and start long acting beta agonist for these patients, considering a lot of worsening of the COPD on COPD, there is a worsening of symptoms. So what you exactly want to do, right? Who will interpret the ABG for me? And who will tell me what is normal ABG and ABG? I will clarify each and everything in these things. A lot of clarity will bring in next 2 to 5 minutes for ABG as well. So first of all, right, what is the picture in ABG? Can anyone volunteer can interpret? Acidosis, alkalosis, respiratory, metabolic, blah blah, lot of confusions. What is normal pH? What is normal PaO2? You need to know. You need to know, right? If they gives you, well and good, I'm happy. But if not, this is life saving. So you need to know the basic parameter. What is a normal pH? What is normal PaCO2? What is normal PaO2 and
Sir,
SCO3?
is it respiratory acidosis?
As
The normal
respiratory
pH
acid,
is
Normal pH is
respiratory.
normal pH is
7.35 to 45.
7.35.
So
One
it is
1 minute. 1 minute.
acidosis.
1 minute. 1 minute. Respiratory acidosis, right?
Yes.
So respiratory
pH low.
acidosis, right? So let me give you the idea, complete clear cut. Then we'll switch to the answer. First, we understand the concept and basic, right? So let me first show you. I had prepared very nice slide for you guys. So this is very important and interesting. Just listen it properly and then we'll discuss again. Absolutely. So this is normal pH scale. Normal pH scale. You must remember normal pH scale. So normal pH scale is what? So this is like baseline 7.35 to 7.45 is a normal.
Okay.
This is pH. This is pH, blood pH, right? So if you are going on this direction, it is acidosis. Everything on the left side is acidosis. Everything right side is alkalosis. Simple, right? So 7.35 to 7.45. Let me mute the all so I won't get distracted
Ranjit,
myself. So everybody is muted. So if anybody wants to interact, you can unmute. So here on the left side, it is acidosis. Right side is alkalosis. Same way, this is pH. This is arterial CO2, PaCO2, right? 45. So anything beyond 45 is acidosis. Anything beyond this, right? So this number is like 45, 46, 47 in that sense. 35, 34, 33 like that, right? So 35 to 45 is normal. So left side, if you're going, it is acidosis. 22 to 26, right? If you're going, right, 21, 20, 19, it is acidosis. 26, 27, 28, 29, alkalosis. So right side you are going alkalosis. So I think anyone volunteer can tell me this concept is cleared or not, yes or no. Without understanding this, it is absolutely impossible to switch on to the any ABG things. Is that clear to everyone, yes or no?
Yes,
Sir.
yes, this is clear.
Wonderful,
Yes, sir.
wonderful, brilliant. Now let's dissect our question, right? So now we put all the things here, right? What we try to put the things here from our scenario. Okay, sorry, something going wrong. Hang up the things. Sorry, yeah. So now 7.28, 7.28 and 62 and 30. Just remember 7.28, 68 and 30. Let's fit it here. 7.28. So 7.28. Where is the 7.28? So here 7.28. Here the 62 and I think 30. Is that clear? Yes or no? So
Yes, sir.
obviously, whenever you see any ABG things, number one thing decide whether acidosis or alkalosis. This is the first step. How you supposed to tell by pH? So pH is 7.28. So it is one thing is confirmed that this is a acidosis. Yes or no? At least tell me yes or no. So this is
Yes, sir. Yes,
anything
sir.
less than, we are going on the left side means acidosis, here going alkalosis. So anything less than 7.35 is acidosis. So this is confirmed that this is acidosis. Now this patient has a respiratory symptoms, this, that, blah, blah. So something wrong in the respiration, right? Something wrong in the respiration, right? So if you are going 62, right? So anything, right? So 45, 46, 47, 61 and 62, right? And here 34, 32, 33. So it going from this to this, right? So if you are going this, it is alkalosis. This is going this. So this is acidosis. So this is very simple, right? This is very, very simple, right? So you need to understand this ABG. This chart is brilliant, right? So now let's go to the questions. Now we got little clarity that okay, what is acidosis, what is the number, what is alkalosis, right? So this is what the question is, right? So now we dissect this question, so we bring the more clarity. It is not that tricky. You need to little concentrate and do the practice of this, right? So this is the thing, right? So now see the things here. The correct answer, start non-invasive ventilation first. This is the answer. We'll discuss it, don't worry. Also, I want to know from you what is the type 1 respiratory failure, type 2 respiratory failure, how it differs from 1 and 2, what is the treatment in type 1 failure, what is treatment in type 2 failure, and what is the causes of type 1 and 2. These are the topic usually by my sense it is untouched for most of the doctors, and it is a little boring as well. So you try to avoid it, or most of the people try to avoid. That is why included. So try to understand and do the practice, then it would be one of the most easiest topic now onwards for you. So explanation is this is a type 2 hypercapnic respiratory failure. What is hypercapnia, right? So there is a difference between hypercapnia and hypoxia, right? So type 1 respiratory failure, type 2 respiratory failure. Type 1, there is a reduced oxygen. Carbon dioxide could be a normal. And here the different. Carbon dioxide is increased, the oxygen could be a normal. So there is a difference. There is a difference, right? Here oxygen reduced, type 1 carbon dioxide is normal. Here carbon dioxide increase. Our is 35 to 45 is a normal carbon dioxide. We have somewhere around 60, 60 to 63. So increase carbon dioxide. Hypercapnia. Cap means carbon dioxide. Hypercapnia means carbon dioxide. So type 2, it is fall into the type 2 hypercapnia, right? It's a respiratory failure. So PaCO2 is 68. What is the normal range? It is 35 to 45. So CO2 is increased, right? Another is pH 7.28. What is the normal? 7.35 to 7.45, right? And increase partial compensation. So whenever there is a respiratory acidosis, there is a metabolic alkalosis compensatory mechanism. So keep a watch on the primary pathology, right? So this is not hypoxia. This is hypercapnia as per the ABG things, right? So let's go a little further and understand the more things about this. Why NIV, non-invasive ventilation? Indication for non-invasive ventilation in type 2 respiratory failure, right? In acute exacerbation of COPD, right? So it is already a known case of COPD, but now presented with the breathlessness, with the wheezing and all other respiratory problem. So patient has a 7 pH is 7.25 to 7.35. If it is there, it is an indication. Now you need to know what are the indication of non-invasive ventilation. pH is 7.25 to 7.35. Our patient has 7.28. So we deserve this. We deserve this, right? PaCO2 is more than 45. Our patient is somewhere around 63, I think, very high. Respiratory rate is more than 25. Our patient has a 30, right? Patient should be conscious and cooperative. Yes, our patient is conscious and cooperative. So NIV reduces the PaCO2, means oxygen or carbon dioxide reduces in our body, and this is what we want in our patient. Our patient has a hypercapnia. Capnia means carbon dioxide, too much of carbon dioxide in the body. We want to reduce it. How we supposed to reduce it? By NIV. You don't need directly ventilator to this patient. Improve the pH, improve the pH. From acidosis it becomes normal, and it decreases the need for intubation, that is endotracheal intubations or mechanical ventilation or ventilator, right? So this is the things, right? So whenever any questions comes to you with the respiratory things, you need to know, despite whether it is and all the respiratory problems, think of respiratory acidosis or alkalosis. So look at the parameter. Number one is pH, number two is CO2. That's it. Rest of the things, if you don't remember, that's fine. You need to know carbon dioxide is high, 35 to 45 is normal. Anything more than 45, it is hypercapnia. And when the carbon dioxide increase in the body, it is acidosis. When reduce, it is alkalosis. Simple. When pH reduces in the body, acidosis. When pH increase more than 45, it is alkalosis. So you need to know the right? The primary and the pathology. Rest is the compensatory. If this patient has a respiratory acidosis, compensatory metabolic alkalosis. That's it. So this is the indication. I mean, I won't help you to remember this, but you need to remember this. You need to remember because it answered lots of question in your exam. What are the indications? So here almost all the indication in our patient, right? So if you go back and read our question, it is absolutely a classical case of this thing, right? So that's it. Now let me check why the other options are not the correct or what they are trying to tell you why not other options. One is high flow oxygen can worsen. Why it can worsen? That is very important for us to know. High flow oxygen will not going to help this patient because there is no problem much in oxygen. There is a problem in the carbon dioxide, hypercapnia. So you need to reduce the carbon dioxide rather than
It's
increase the oxygen. It is not required here. It is required is the reduced and BiPAP or non-invasive can help in this, right? So it can rather if you give the oxygen, right, can worsen the CO2 retention in COPD. This is the worst thing. So rather doing good, you are doing bad for patients. So every dyspnea patient does not mean that they need oxygen. This is our mindset. Every dyspnea patient in the emergency room, right, will give the oxygen. Don't give oxygen to each and everybody. Try to understand type 1, type 2. So now onwards, ask your questions, which is type 1 or type 2. We'll see the causes as well, just to get little more clinical clarity, right, what it is suffering from. So what will tell you it is type 1 or type 2? It is ABG, right? Arterial blood gas. So you get it from the radial or femoral or artery and try to check it out. What is CO2? What is O2? If you have hypercapnia, try to reduce it, not the oxygen. This is what the case is. And here the target is 88 to 92. Immediate intubation or endotracheal intubation or these things only if HB is 7.25. Worsening acidosis despite non-invasive ventilation, and if patient is going in unconscious or arrest, you have no options than ventilator, right? So you need to do it, right? So these are the again indication for this. Likewise, so you need to know the indication of intubation and indications of non-invasive ventilation or BiPAP, right? That already we discussed it. Sodium bicarbonate is respiratory acidosis, right? Treat ventilation, not the bicarbonate, right? So you need to treat the ventilation, not the bicarbonate. Only giving or pushing the sodium bicarbonate will not suffice. You need to do something more aggressive to reduce the CO2 level. And long-acting broncho dilator or long-acting beta agonist is it is for the maintenance therapy, not for the acute management, right? So acute management, probably you must give the SABA, short-acting beta agonist, salbutamol. So that's all from my side. So this is like the final clinical poll for us. One line example, type 2 respiratory failure plus pH 2.70, 25 to 35. Non-invasive is first, not intubation. So that's all. This is what the head-to-head comparison between type 1 and type 2. I would like to emphasize that as well very quickly. So type 1 and type 2, what is the difference between type 1 and type 2? I already mentioned you, but I'll give you this is hypoxia, so oxygen is low, and this is hypercapnia, carbon dioxide is high. So primary problem, oxygen failure, here ventilation failure, right? So it's a difference between oxygenation failure, right? Means oxygen does not get dissolved into the blood. There is a hypoxia and it's a ventilation problem, ventilation perfusion problem. So PaO2 is reduced here, reduced or normal. PaCO2 is normal or reduced here, high, absolutely high because it's a type 2 hypercapnia. So here the CO2 is high, high and high. Here normal or low, but not the high, absolutely not high, not high. Right? pH is normal or alkalosis, and here the acidosis, high CO2, high carbon dioxide, and it's a normal is 35 to 45. Anything more than 45 is hypercapnia, right? So, and high oxygen in the body means acidosis, low carbon dioxide, sorry, high carbon dioxide is acidosis, and low carbon dioxide is alkalosis. So, this is acidosis. Why? Because hypercapnia, high CO2 in the body, you need to remove it from body, right? Then important is oxygen failure. So, VQ mismatch, shunt diffusion defect, and here the alveolar hypoventilation. At the level of alveolar hypoventilation, alveoli cannot. What happens when you inhale, you get oxygen inside the body, and when you exhale, you remove the carbon dioxide from the body. So oxygen is inhaling, carbon dioxide is going out. What happens? This carbon dioxide does not get out of your body. It's hypercapnia. And where is the problem in hypercapnia? Alveoli, right? So this is a main bronchus. This is trachea. This is right and left main bronchus, right? We need to know this is main bronchus, right and left, divide into two. They divide in many things. This is called as a bronchiole. So bronchus and then bronchiole. This is the story, right? Just for under trachea, bronchus, bronchiole, and eventually the air-filled air sac alveoli. This is for general understanding, right? So problem is here alveolar hypoventilation. Here problem is here, right? So what we do is usually oxygen is going inside while we inhale and while we exhale CO2. So because of this alveolar problem, carbon dioxide cannot get out of this alveoli to bronchus and to trachea and exhale. It's not happen, right? That is a problem, and that is why CO2 retention in the alveolar hypoperfusion. Response to oxygen is improve or excellent. Why? Because problem in the oxygen. So it improves. If type 1, if you give the oxygen, it improves. Type 2, if you give, probably you worsen, right? So here limited oxygen, if you give the oxygen to this patient, right, limited use or no use, risk of CO2 retention. And key ABG clue, low oxygen with normal dioxide, right, because it's type 1 hypoxia, so oxygen is low. Normal CO2, likewise here high CO2, normal or low, normal this oxygen, right? So that is the primary mechanism. So we must understand what is going wrong with the type 1 and 2, right? Which is very, very important in the clinical practice. So we don't need to transfuse each and every patient. What are the example of type 1 and type 2 respiratory failure, right? Let me remind you, right? So type 2 respiratory failure is alveolar hypoventilation, alveolar hypoventilation, right? So let's see first two, right? So COPD exacerbation, severe asthma, right? Obesity, hypoventilation syndrome, neuromuscular, so right, Guillain-Barré syndrome, right? And myasthenia gravis, it's a muscle problem, CNS depression, opioid, sedative, even I can include head injury, right? There is no problem in the oxygen, there is problem in the CO2. So these all are the condition in short where the CO2 retention is there. So think all the conditions. COPD, yes, CO2 retention. Asthma, you can inhale well, but you cannot exhale well, so CO2 retention. This is also obesity syndrome. You cannot exhale well, right? Neuromuscular things you can inhale, but exhalation is important, not there. Head injury, patient is coma, sedative, opioids, right? So you can take the oxygen, but you cannot remove it. Respiration is, and chest wall deformities like kyphoscoliosis and all. Rest of the all thing is type 1 failure where the oxygen is at problem. So pneumonia in emergency room, type 1 failure, give the oxygen. ARDS, give oxygen. Embolism, hypoxia, give oxygen. Pulmonary edema, give the Lasix, diuretic, give the oxygen, treat the underlying cause. Interstitial lung disease, give it. Severe asthma with hypoxia, you can use it with the oxygen, not the type 2, treat with the oxygen. It's a hypercapnia, remove the carbon dioxide from the body. Fine. So last line or last this slide for you for this question, management principle, right? So what are the management principle? In short, this is summary. If you did not understood earlier well, remember high flow oxygen in type 1 by because it's a hypoxia, controlled oxygen. You can't give a lot of oxygen, 100% oxygen. You don't need here just 24 to 28, right? Just to drive the respiratory system. Ventilation, right? If refractory in type 1, right, you can use the IMV or CPAP. Here in type 2, NIV first, IMV fail, mechanical ventilation. Target is to correct the hypoxia. Here target is to reduce the CO2 because it's CO2 retention, hypercapnia, and work of breathing. You need to work on it. SpO2 goal is more than 94 because oxygen low. Here not 94, 90% or near 90% would be fine. Not a problem in the oxygen. So you don't need to keep and desire the very high level of oxygen. Rather it will worsen as we seen it. So that's all from my side. It looks little complicated but very, very important subject. So once again go and read it. So concluding our talk and questions, go back to the questions. Now we learn a lot of things. A 68-year-old man with known COPD, right? So COPD is until proved otherwise CO2 retention, irrespective, even if you don't see the ABG, something with the CO2 retention, right? It's not type 1, it's type 2. CO2 retention present with the worsening dyspnea, wheeze, and drowsiness. Respiratory rate is high. SpO2 is 86%, already on the 24%, which is desired oxygen you are giving it, right? This is showing the respiratory acidosis, right? So you don't need to increase the oxygen. Increase oxygen. Why you don't need to increase? We have already seen it, right? It will not improve, right? And it will not improve. You don't need to improve the oxygen. Here in this case, you need to reduce the carbon dioxide. Immediate endotracheal intubation is only indication when the non-invasive gets failed. So first try with the non-invasive. If fails, then invasive. Bicarb and LABA will not help, right, for these things. So that's all from my side. I think I tried my level best to make sure these questions would be clear to you. So I want and wish everyone to go and read it once again for this all complex or complicated ABG. And we have a lot of questions on our website. You just uh, this try to solve it in the respiratory and emergency module, right? So you get the more clarity, and we'll discuss. Let me have, I mean, time is going. I think you people are also hypoglycemic. So let me cover one or two questions if you allow me. Is that okay with everyone? Audience, one or two questions is okay?
Yes, sir.
Sure, sir. We will
Wonderful.
Yes, sir.
proceed.
Wonderful. So 58-year-old woman presents to the emergency department with sudden onset of severe headache, eye pain, blurred visions, and halos, nausea with vomiting for past 6 hours. She recently took an antihistaminic for the cold symptoms. On examination, you see eye is red, cornea is hazy, pupil is mild, dilated, and fixed. Intraocular pressure is 52. What is the most appropriate immediate management of this patient? So before going and jumping to the questions, as I regularly told every doctors, this triad is extremely important: diagnosis, investigation, and treatment. So without knowing the diagnosis, how you supposed to jump on the treatment? So first you have to make some impression by these three lines. What is the diagnosis? So just keep in mind what's the diagnosis, then this job would be easy for you. What is the most appropriate immediate management for this patient? Topical atropine, topical timolol plus IV acetazolamide, topical steroid drops only, oral prednisolone, or it's fine. You reassure the patient, tell him come after 24 hours. If does not improve, we'll do something for you. Yes. Ophthalmo question. Yes, please. Yes, post your answer in the chat box. Probably we'll keep it at the last just because time is over now. Yes, anyone? Anyone? What's your answer? Yes, Khadija, any comment on
Yes,
this
B.
from your side? So what is the diagnosis? I'm first interested in the diagnosis, then discussion. What is the diagnosis? Okay,
Glaucoma.
Acute angle closure glaucoma, sir.
this is glaucoma. Open angle, close angle. How
Close
you
angle.
differentiate?
Close.
Close angle, close angle glaucoma. Okay, fine. So you confirm the things that this is a close angle glaucoma, right? So what? How did you get the idea of this close angle glaucoma? What point favors the close angle glaucoma? Yes, Khadija. Fine.
It was
And
precipitated.
yes, go ahead. Sorry, go ahead.
He had a sudden onset headache, and there's blurred vision with halos
Hmm.
and also nausea. And it was precipitated by an antihistamine. And the pupil is mid dilated and fixed, which is also one of the main points for glaucoma.
Okay. So how you supposed to reduce this all symptoms and signs and all haziness and pressure? How you supposed to reduce it? That is the management basically. So how you
The
supposed to
acute
reduce?
issue, the acute issue is the increase in intraocular pressure. So you would prefer to do things that would reduce the intraocular pressure. So you can give topical timolol for reducing the acute production, and also IV acetazolamide in the short term.
Fair enough. Fair enough. So let me first give you the differentiation of acute versus chronic glaucoma, primary open angle and primary close, right? So just get the more clarity here, just right. So probably I'm asking you close angle, but they may ask you in exam the open angle, so you need to know both the things, right? So let's see the open versus close, open versus close angle glaucoma, right? So it is a chronic. Open is insidious and chronic. This is sudden and acute, like our case. Pain is absent here. We have a severe pain. Our patient has a severe pain. Our patient has a headache. It's close angle. Red eye, no. Chronic, our patient has red eye. Yes. Vision loss, gradual loss. This is acute loss. Blurred vision and halos. Our patient has a halos. So our case is classical. Pupil is normal. Here the pupil is mid dilated and fixed. Cornea is clear. Here cornea is hazy. It is also there in our case. IOP intraocular pressure is chronically increased here. The markedly increased more than 40 to 50. I think our has I think 60 or plus or something. Anterior chamber normal in depth. Here the shallow anterior chamber, right? Because of the angle is distorted. Then if we can see open angle here, the genioscopy here open and close. We are not doing very much in the practice. Anyway, I'm not doing being a meteorologist, but I will less seen in my practice. Optic disc, yes, by retinoscope or by ophthalmoscope, you can see the cupping, and here hyperemia early, cupping is the late. Here you can see the early cupping, and visual field, peripheral constriction, here generalized depression, acute. So this is the general differentiating point. So by sign and symptoms, even you can tell without intraocular pressures as well, because patient has a classical, right? So close is bad than open. Remember in that day. So they have sudden onset, they have severe pain, they have red eye, they have reduced vision, right? And they have markedly increased the pressure. So this is classical for close angle. So if you remember close, rest of the thing is open. That's it. Right. So now our job is bit more easy here in this case now, because we know now what is the difference between close and acute now. Right. So this is classical, right? See, now go and see, check it once again on the history only. Sudden onset and severe headache, close. Eye pain, close. Blurred vision and harrow, close angle. Nausea, vomiting, close angle. And this is the precipitating factor, right? Eye red, which is there in the close, not in the this. Cornea is hazy, pupil is mildly fixed, more than 50, 52. So it is absolutely classical for close angle and glaucoma, right? So that's it. This is one point is very much clear, pretty much clear from our side, right? So now let's see what is the explanation for this, all the options we dissect. So topical timolol plus IV acetazolamide. So explanation, exam focus. This is a classical case of acute angle closer glaucoma, acute closer angle glaucoma, closer or close angle. So this is the feature: sudden eye pain and headache. Why? Significant acute rise in intraocular pressure. Halos around the light, something wrong in the cornea, it is edema. Nausea and vomiting, it's a part of increased intraocular pressure, right? Mild dilated and fixed pupil, iris ischemia, and triggered by antihistaminic, right? So this is the overall completely fitting our case, and what and how the things will change because of these things. Where is the problem? So our why not the other option? Atropine is why the not option. It causes the pupillary dilatation, worsen the acute angle closure. So this is the worst thing. Adding the atropine in this patient, making the things worse, right? So instead of constriction, it causes the dilatation. It will reduce the angle and it will again aggravate the symptoms. So atropine is worsen the close angle glaucoma. Steroid drops alone does not reduce the intraocular pressure. It probably reduces the pain inflammations only, not the intraocular pressure. And oral prednisolone, not an emergency therapy, and reassurance is absolutely difficult to do it in this patient. It is a very high acute severe close angle glaucoma, so you must have to do something for this patient. So it's an ophthalmic emergency, so you can't wait and watch for this patient. So one line final poll is painful red eye plus mid dilated pupil plus vomiting acute close angle glaucoma, use acetazolamide and timolol. That's all. And what is the management aspect? open angle versus close angle. So it is a chronic, it is ophthalmic emergency. So close angle is ophthalmic emergency. Like this patient, first line treatment is IV acetazolamide and topical timolol. Here the prostaglandin analog you must know. So this is head-to-head comparison. Avoid nothing much to be avoided here. Here what you avoid is anticholinergic or atropine drop, which worsen mydriatic means dilatation of the pupil, which again worsen the or close the angle of this iris and this cornea. So you should avoid the atropine. Remember this: close angle, avoid atropine; close angle, avoid atropine; close angle, avoid atropine. That's it. Even if you remember, you can rule out a lot of things. Definitive treatment is long medical in open angle, long term medical treatment plus or minus surgery. Here, laser peripheral iridectomy. Why you want to remove the iris? By removing the iris, you are opening the angle, you are trying to reduce the symptoms, you are trying to reverse the pathology, and they should be immediate. So there is nothing like, so you use the drug, but definitive treatment is not the drug. So whenever you put the drug in acute severe cases, it gives relief for 6 hours, 12 hours, 24 hours. Again it will recur with the things, right? So you need to do immediate treatment as well as definitive treatment. Immediate treatment is IV acetazolamide plus this topical timolol, right? And the permanent or definitive treatment is this, right? O2 roll, none here, nothing, right? So last but not the least, one line Paul for this: painless, without pain, progressive visual loss, vision loss, so open angle, painful red eye, close. So this is one of the extremely important. Whenever any patient comes to your OPD, ask the number one question: do you feel pain in the eye? Yes, close angle; no, open angle. That's it. This is simple one question, probably solve lots of queries to your mind. And mid dilated pupil means it is a close angle. And lentoprost POC, this is the drug. POAG is the first line. If you don't remember, that's fine, so don't get stressed. So that's all from my side, and if you wish, I can take one more MCQ with your kind permission. Yes or no?
Yes, sir. Please.
Wonderful. Last
Yes,
question
sir.
for sure today. So just be with me more 5 minutes. I'm also a little hypoglycemic, but I'm going with the full energy. Which BIRADS categories indicates a known malignancy? Which BIRAD? BIRAD, first of all, let me tell you what is BIRAD if you don't know, right? So BIRAD is a screening, it is a reporting. So for the screening breast cancer, we do a mammogram, right? We do a mammogram. Mammogram is screening test for breast cancer. Early detection of breast cancer is we do the mammogram. Mammogram is reported. Once the report of mammogram comes, it reported in a BIRAD score. BIRAD score. Breast imaging radiology and data system. This is the full form of BIRAD. Breast imaging reporting and data system. Like for breast we have BIRADs. For prostate we have PIRAD. For prostate we have PIRAD. For thyroid we have TIRAD. Just for your knowledge, I'm telling you, because we use it every day in our oncology practice, because I see all 100% cancer patients. So this comes every day in my practice. So BIRAD is a breast imaging, reporting and data system. So this mammogram is reported as like BIRAD 0, BIRAD 1, BIRAD 2, max is BIRAD 6. So this is what the scoring is, just for your kind knowledge. So they are asking which BIRAD category indicate known malignancy. So if the BIRAD 1 is a malignancy, known malignancy, 2, 3, 4, 5, 6. So what's the answer? Number one. This is one question. Second question, what is BIRAD? I all told you. BIRAD is what? Right? So BIRAD is a breast imaging reporting data system. It is used to know the scoring of mammogram report, and on that whether you need to do conservative versus biopsy versus surgery. You decide on this score, right? Higher the score, bad the things. Higher the score, bad the things. Right? Best is BIRAD 1. Worst is BIRAD 6, just for your knowledge. So what is BIRAD? How to score? Importance of BIRAD, advantage of doing the BIRAD, these all are important. So BIRAD, I told you, BIRAD tells you, right? BIRAD tells you how worried to be and what to do the next. So on BIRAD, whether to worry or not, this is one thing. If BIRAD score is 0, 1, you don't need to worry. BIRAD 6, it is matter of concern. And if you have BIRAD 0, don't worry, number one. And number two, whether to do some treatment or not, number two. So these both things are very, very important for us to know on the BIRADS, when BIRAD stands for the breast imaging, right? So this is what the thing is. So let me, so anybody has any clue what is the answer for this? Which BIRAD category indicates a known malignancy? Known malignancy, BIRAD.
BIRAD 6.
Wonderful, brilliant. So you are absolutely right. So BIRAD, as I told you, absolutely. So BIRAD breast imaging reporting and data system is standardized reporting system globally. The word is not mentioned here, but I'm adding this. This is globally. So if you're doing UA in BIRAD or in America or in London or India, BIRAD would be same. This is the international scoring system for BIRAD, right? How to score. So 0 to 6 is the score, right? And it is developed by the American College of Radiology for mammography reporting, breast ultrasound or MRI. So whether you do MRI of breast, you do the ultrasound of breast, or you do the mammogram of breast, you categorize in BIRAD, right? Reporting must have mentioned BIRAD 0, BIRAD 1. This is a job of the radiologist. What he can see in the USG or MRI or CT scan or mammogram, he must report, because on the scoring, I will decide whether to biopsy or not. That is very, very important. This score carries the risk of the development of malignancy, where if someone says 0 and 1, I will not do it, I will do follow up. 2, I will follow up, closely follow up, instead of 1 year here, I do it 6 monthly follow up, right? Or 3, probably the same. 4 and 5 is highly malignant. I will insist them to go for the true cut biopsy or core needle biopsy. And 6 is a biopsy proven cancer. Once biopsy you done and cancer, it is BIRAD 6. So if some patient has a breast lump, they have breast lump, they have done the biopsy, biopsy proves that is invasive ductal carcinoma, and they do the mammogram, it is BIRAD 6. So you don't need to worry, it is already biopsy proven. So how we did do the things, and how you have to tell the patient whether biopsy is required or not, reassurance versus the aggressive things. So category 0 is incomplete, adding imaging. So this is incomplete or poor quality, incomplete or poor quality. So you need to repeat it here. Manage additional image and you repeat it. One is negative, routine screening. So 50 years of female did the mammogram, BIRAD score is 1. You tell them 1 is negative, nothing to worry, no breast cancer. You do every 1 to 2 year routine mammogram. That is your advice, right? 2 is benign. This is negative, absolutely negative. This is benign, benign finding. Again, the routine like 1. 3 probably benign. 3 probably benign. Probably benign. Less than 2% risk of develop. So here you are giving the advice here. Follow every 1 to 2 year mammogram. You do it. Here now see the change. 6 month at 3. 3 is like little borderline. It is more likely benign than malignant, but it is probably benign, not 100% benign. So negative, benign, probable benign, and 4, 5 is a suspicious. Biopsy is absolutely needed. Anything for more than 4 or more than 4. 5 is absolutely very, very high risk of malignancy. More than 95% patient will turn up after biopsy into a cancer. So 4 and 5, just remember 4 and 5. So whenever mammogram comes to my OPD tomorrow with some female, I'll look at the BIRAD score. I look at the picture. I look at the calcification. Okay, BIRAD 4, 5, go and do it the biopsy. If BIRAD 1 and 2, right, you don't know, need to worry. BIRAD 3, don't get panic, repeat after 6 months, right? If it is going from 3 to 4, go and get the biopsy. So this is 0, 1, 2, 3 is little less risky. 4, 5 is absolutely you need a biopsy. There is no other discussion or consensus, right? And C is biopsy proven, known biopsy proven malignancy. Treat as per the stage of the patient. So that's it. You need to know the BIRAD scoring. You need to know the PIRAD scoring. You need to know TIRAD scoring. So that's it. So this is what the thing is. So example, last slide. BIRAD's 5 suspected cancer. Let me add one more things, like not 4, not 5. 4 and 5 is suspected cancer, and this is confirmed cancer, right? Importance of BIRAD is what? Importance, as we discussed. What is the importance? What are the advantage? So importance, ensure uniform communication between radiologist and clinical. Sir, BIRAD class 4, I will going to go for biopsy. Clear cut communication, radiologist and myself. Reduce the interpretation error, right? If there is no international scoring, somebody will report 2, 3, 4 their own way, nothing. It reduces the interpretation error by doing the BIRAD score 0 to 6. Directly links imaging finding to clear management decision, essential for screening program and audits as well. Right? Advantage of using standardized reporting worldwide. It is globally, not in the some few countries. Globally, it's a BIRAD is the same. Avoid ambiguity in the report. So, I mean, there is a personal bias is gone, right? Guide biopsy versus follow-up. So, 1, 2, 3 follow-up, 4, 5 biopsy, 6 biopsy proven cancer. That's it. This is as good as that. So it guides the biopsy or not to biopsy, follow up or not to follow up decision depends on the score. That is why we need a score. Improve patient safety and outcome, and high yield and frequently tested these things in the exam. So that's all from my side. Thank you very much all for listening me coolly and calmly, and thank you very much once again for Dr. Akanksha. I have many more questions to discuss, but considering the time slot and frame, we are stopping here. And thank you very much. Before ending the session, I would like to have suggestions or your feedbacks very quickly for next 1 more minute that will help us to grow better and improve our quality of education better. Anyone? Anyone? How did you enjoy it? You can obviously, I mean, comment little bit. Na?
Excellent lecture, sir. As usual, you are explaining very well, very complex things. You are explaining in a very simple manner. Thank you very much, sir. We are really enjoying with joining your program.
Wonderful, brilliant. Thank you very much. Anyone else? Dr. Rabia, Dr. Deepika, how did you enjoy Khadija? Dr. Ramya is also joined. Dr. Tushar Balakrishnan. A lot of doctors still there. Yes, any comments, sir?
Yes, sir. It was an excellent lecture and very informative. And I cleared many doubts from your lecture and very
Perfect.
informative. Thank you
Perfect.
very much.
Great.
So I like the variety of questions today. I wish you had continued for a little while longer.
We will next time. So that's all. We are stopping here. Thank you
We
very
are
much.
tired, but we are tired.
Wonderful. I am non-stoppable.
Not bad.
I'm unstoppable. I can take for 4 hours, but considering your brain level and your brain and neurons energy, I'm stopping it here. And Dr. Akankshha is a super duper speaker and
Sir, we
batsman,
could
as you
take
have seen.
a mega session one day for 6 hours also togetherly.
Wow.
But then students will
So,
be like,
Small
what is
breaks.
this doing?
so then they will not join from the next class for you and me.
No, no,
We'll
we'll
keep it
join,
at
sir. Just give small breaks. That's it.
We will give you small breaks, but we once a month will take a 4 hour session. In that,
fair enough.
we'll cover up almost how much our MCQs or the topics.
Fair enough, madam. I respect your wish and your courage and your energy, and I loved a lot, Dr. Akanksha, your lecture. It was super brilliant. Believe
Yes,
me.
sir. We also learned a lot from you, especially the one Willebrand factor thing. It was very confusing, but you
Ah,
made it very simplified.
Wonderful. Thank you very much. That is my core area of interest, hematology. So obviously, thank you very much once again, everyone. So
Yes.
stay
Thank you,
tuned
class.
and
Thank you,
you take care.
students, for joining us. See you next
Thank
time
you, ma'am.
soon.
Thank you very much, sir.
Thank you,
Thank
ma'am.
thank you so
you.
much, sir.
Excellent lecture.
Thank you, ma'am. Thank you,
Yes, just
ma'am.
don't
Thank you,
don't
ma'am.
forget to post a little review of yours on the Google. Our Google is there. Google review, so that help us to grow. Make some 4 star, 5 star, preferably five. I'm not forcing you. You do your own judgment. How you enjoy depends on that. You can give it. Thank you very much. Take care
Thank
and
you.
enjoy your Sunday. Bye bye.
Thank you very much.